Yes, ma'am.
So a very warm good evening to all the esteemed panelist moderators today and to all our delegates to the AAOS Saturday evening lecture, the first virtual series of 2021. As you all are aware that the program starts at 8:25 with a welcome note by Dr. Dilip Shah and talking a little about our moderators. I take this opportunity to welcome the Honorable Dr. Dilip Shah. Dr. Shah is an honorable professor in orthopedics, winner of the highest fellowship of CCOT, Italy, 1985, instructor for the AO course since 1985, awardee of the AO International Fellowship, Germany in 1995, winner of the National Fellowship in 1989, recognized professor in the University of Bombay, examiner for the postgraduate MS examination, recognized inspector for recognition of hospital for the postgraduate teaching, fellowship BOS EMERC, editor-in-chief of the international journal ASOR, on the editorial board of the prestigious Journal of the Orthopedics, Journal of Orthopedics and Scientific Research, and also attached to various organizations in various capacities. Dr. Shah is the main coordinator for more than 48 cities in India and moderator for the Saturday evening webinar CMEs with AOS Rosemont, Chicago. Maximum number of webinars and virtual orthopedic conferences conducted on various topics of orthopedics for more than 5,000 participants. Honorable orthopedic surgeon at Saifee Hospital, Nanavati Hospital, Breach Candy Hospital, Kothari Hospital, ex-honorary consultant at HN Hospital, ex-honorary orthopedic surgeon and HDU at Nair Hospital and professor at TN Mehta College and panelist at the ONGC Hospital, has many publications and papers at national and international level, and has been an active sportsman and musician. I take this opportunity to welcome Dr. Dilip Shah for the Saturday evening lectures. Our next esteemed panelist is the Honorable Dr. Gurinder Bedi. Dr. Bedi has been associated with the Fortis Hospital, Delhi, and previously worked in Max Hospital, Primus Hospital, and Sitaram Bhartiya Hospital. Trained in Delhi Premier Institute of Institute MAMC, and then worked in England for 11 years for various university hospitals around Bristol, Newcastle region. Having trained and worked extensively in the NHS UK, he has varied special interest in areas such as joint replacement, both in the lower limb and the upper limb, arthroscopy, foot ankle surgery, and spine surgery. Dr. Bedi has done advanced fellowship in knee replacement, hip construction, and also foot, ankle, and deformity correction. Regularly invited for lectures in DOA, IOCON, ISCSA, and other national meetings. He is an AO, trauma trainer, and is the viewer for Indian Journal of Orthopedics, Journal of Clinical Orthopedics Trauma. I take this opportunity to welcome Dr. Bedi for the program tonight. I also take this opportunity to welcome the Honorable Professor Dr. A.K. Pal. Dr. Pal, the youngest professor at the age of 42 years and head of the Department of Orthopedics and Traumatology, IPCA, SSKM Medical College, Kolkata, West Bengal, with 35 international and national publications in indexed journals, author of the book on an atlas of orthopedic surgery, selected as one of the inspiring orthopedicians in India for the year 2019 by Economic Times, winner of the AA Mehta Gold Medal 2002, best scientific presentation of a session in IOCON 2003, best paper in implant section as a co-author in IOCON 2004. Johnson & Johnson Traveling Fellowship of the IOA in 2007, SN Bakshi Medical Gold Medal Award for the best publication in Indian Journal of Orthopedics 2012, National CME lecturer, reviewer of the Indian Journal of Orthopedics. I take this opportunity to welcome Dr. A.K. Pal to tonight's program. I also take this opportunity to welcome the Honorable Dr. Subhash Jangid. Dr. Jangid is currently working as the Director and Head Orthopedics and Joint Reconstruction at Fortis Memorial Research Institute, Gurgaon. Introduced to the world's most advanced NAV3 computer navigation technique for joint replacement and Navio robot for knee replacement for the first time in India, reviewer of Journal of Orthoscopy and Joint Surgery by Elsevier. He has a vast experience of more than 19 years and 10,000 surgeries in the field of orthopedics, visiting faculty to the Namadi Teaching Hospital, Nigeria, General Secretary of Gurgaon Orthopedic Society from 2012, member of the Royal College of Physicians and Surgeons, Glasgow, UK, and life member of IOA, ISHKS, DOA, BOS, ROSA, GOS, FOSMI, ISSA, and NAMS. I welcome Dr. Jangid to the program. I also take this opportunity to introduce the Honorable Dr. C. Ravi. Dr. Ravi has a fellowship in arthroplasty and WOC fellowship in arthroscopy, head of the Department of Orthopedics, Mahavir Institute of Medical Sciences, with 24 years of experience in orthopedics, presently working in Apollo Hospitals, Hyderabad, was associate professor at Deccan Medical College of Medical Sciences with a teaching experience of 15 years and is presently there. And main area of interest is joint replacement primary, difficult primary, and revisions, and special interest in pelvic and acetabular trauma. I take this opportunity to welcome all our esteemed panelists of moderators on behalf of IPCA Laboratories. We at IPCA are a fully integrated Indian pharmaceutical company manufacturing over 350 formulations with 80 APIs for various therapeutic segments. And with Zerodol, which is a perfect partner that understands your patient's pain like no one else, for every kind of pain, whether it is an acute or a chronic pain, the #1 brand in managing pain with 12 crore satisfied patients every year. We understand pain across 27 countries. And in the Zerodol basket, we are very pleased to announce that now we have introduced the new SKU, that is Zerodol TH Max 4 and 8 milligrams, which is an aceclofenac 100 milligrams, paracetamol 325 milligrams with thiocolchicoside 4 or 8 milligram tablets, where Zerodol TH Max offers relaxation with maximum mobility. On behalf of the Zerodol team, I take this opportunity to welcome all the delegates, and with this, I hand over the session to our esteemed moderator, Dr. Dilip Shah.
A very good evening to all the viewers and listeners. I am Dr. Dilip Shah from Mumbai. Extend my warm welcome to you all to the first webinar of AAOS Saturday Evening Lectures virtual series of 2021. Although this is the 16th webinar, this is going to be on distal tibia fractures and below knee trauma, resolving the unsolved, organized by IPCA Laboratories, post-successful AAOS Saturday Evening Lectures virtual series of 2020. Forward to having yet another insightful series of knowledge and experience sharing with our colleagues from AAOS and India. AAOS is the global leader in orthopedic learning, and since 2017 we have been gaining many insights and exchanging ideas and knowledge with our fellow colleagues across the globe via the Saturday Evening Lecture Series. Today we have Dr. Frank Avilucea and Dr. Martin J. Herman from AAOS joining us for the question and answer session, along with Dr. Gurinder Bedi from New Delhi, Dr. A.K. Pal from Kolkata, Dr. Subhash Jangid from Gurgaon, and Dr. C. Ravi from Hyderabad. Today's agenda will cover the following topics: lower extremity fracture reduction tips, tricks, and techniques so that you leave the operation theater and this session satisfied. Distal tibia nailing, new pearls and techniques in tibia nailing, open tibia fractures management and update, pediatric fractures of the tibia, ankle, foot. Let us now begin our session from AAOS faculty and connect for the interactive question answer session, which will be happening at around 9:50 p.m. I request everyone to send in your questions in the chat box to make it an enriching session with great interaction. So I request our international faculty from AAOS to take over. Over to you, sir. Are you from Rosemont or for your own places? Because we have been always doing from Rosemont, Chicago, but this time maybe you are in your own houses. I'll stop sharing my screen so that you can share the screen and proceed with today's wonderful session on distal tibia fractures, injuries around the ankle, including pediatric fractures.
All right, well, I don't have any disclosures relevant to this talk. If anything, I would like you to take away 10 recommendations. One, I think semi-extended nailing is effective. It works well. It makes it easy to get a reduction, maintain the reduction, and then it facilitates insertion of your nail. Don't hesitate to obtain a CT. So for periarticular injury, sometimes we're staging them. Perhaps you're fixing one column or the other, and you want to make sure that you understand the fracture pattern when you come back. So I don't hesitate to obtain a CT, especially in the lower extremity. It's worth less than one chest x-ray. Measure length of your distal segment. That's really important if you're going to consider nailing. So remember, the physeal scar is a terminus of where that nail is going to end. So have a good understanding of that and the implants you're using. Make sure you're assessing your articular injury well, understanding impaction, how you're going to reduce it, particularly in whether it's an ankle or a pilon fracture. As I already mentioned, length alignment rotation is incredibly important. I always say begin with an easy reduction. Give yourself something that you can get, make it right, and then build to that. Use percutaneous clamps when you can. I'll show you some cases where it's very effective. Mini fragment plates are also equally effective. But remember, especially in the diaphysis, you really need a balance of forces there with something that's a real construct. Obtain intraoperative radiographs. So sometimes the C-arm is not going to give you the field of view that you need to assess the correct alignment. So if you need to, get an intra-op flat plate so you understand that. And then for ankle and pilon fractures, really become adept with the posterior lateral approach. It's really a workhorse approach. You're getting to the back. You can address not only the distal posterior tibia, but you can also address the fibula. So I would become adept with that. So let's start with distal tibias in terms of nailing versus plating. So, as you probably understand, it's quite the spectrum of injury that can either be low or high. So the question becomes, well, how are you going to treat it though? You going to nail it, plate it? How do you make that decision? So as I mentioned, understanding the implant, how short of a segment you have, but other factors that may play a role is, do you have impaction? Do I understand the complexity of that articular injury? Or perhaps it's a big open injury and you don't want to have an exposed plate. So length alignment rotation, how do you get that? Well, you can assess length before you drape out. You can use a radiographic ruler. You can prep in both legs. You can use intraoperative radiographs, and then say for a syndesmotic injury, you can always get a contralateral image to have a sense for where you need to address your fibula. So in terms of operating room setup, I like supine, as you guys have already seen. It's often on a radiolucent table with the leg free at the end, a bump and bone foam. In terms of nailing, semi-extended technique, which was described by Dr. Tornetta, but it's really evolved. So not only is suprapatellar nailing now in vogue, but there's also an extra articular technique that's also effective. For that particular technique, though, you got to have a very mobile patella. So if you have a 19-year-old girl and you don't want to nail through the joint, you can use that technique because oftentimes you're going to be able to mobilize that patella either medial lateral and stay extra articular. So standard tibial nailing. this is what I learned, but as we all know, the difficulty with it is that you're having to flex and extend the limb. And then depending on how good of a C-arm tech you have, imaging can be tough. So the advantage with semi-extended technique is now the limb is stationary. It's quite easy for the tech to get the correct imaging you need. And then in terms of your fixation, you can not only achieve a reduction, but you can maintain it. And then you can prepare the tibia and maintain that reduction you get. So how effective is suprapatellar nailing for distal tibial fractures? Well, here's one series as multi-center over 200 patients that looked at standard nailing versus suprapatellar. And in the suprapatellar group, there was improved alignment by almost sixfold. So it's a very effective technique. That being said, remember in the distal tibia, you always got to ream through a reduction. So in this particular case, yeah, it's a mid-shaft isthmus fracture. You would think that just simple reaming would get it right, but as you can see, the canal is fairly capacious. And if you don't ream through a reduction, you'll end up with a malreduction. So that's really important, particularly in distal tibia. We talk a lot about where the nail should start proximally, but also recognize that it's now been shown that there's probably an ideal terminus for where the nail should end distally to help you maintain or have a good alignment and good reduction. And that is particularly on the mortise view, if it's just slightly lateral, that's going to give you a correct alignment. The lateral, on the other hand, is going to be somewhat variable, just depending on the anterior bend of that nail. But what I usually use is I get the mortise, I have it end just lateral, and I know that I'm going to be correctly aligned. So in terms of techniques, well, percutaneous clamping has been described. It's effective, but it's also safe. It doesn't increase your chance for wound complications, infection, or non-union. And if you apply that concept to a distal tibia, you have a closed spiral segmented injury. You can clamp it, sight your tines before you with a fluoro before you start. Make sure that you start on the lateral or anterior lateral side. Small incision, pierce the fascia, get the tine exactly where you want on the bone, and then place it where you want medially. Through that, once you get your reduction, you can then prepare the tibia. Maintain those tines are really nice and tight while you're reaming. Put your nail down, and remember, keep those tines or those clamps on until you've locked it up, just to avoid having the fracture or the deforming forces displace it. So you don't end up losing that nice reduction you achieved. So it's a very effective technique. It works well, and again, the chances for a complication are very low. We've heard a lot about unicortical plating wells. Can also be used in the distal tibia. So particularly if it's an open fracture, right? So now you have an injury that's amenable to just placing a plate, maintaining the reduction, and then moving on to fixation. And then in terms of leaving it there, well, I personally don't like to have plates if they're localized directly under a wound or anterior medially. So oftentimes I tend to remove them. But if you're working in a region where it's going to be covered up and you have good soft tissue coverage, it's not going to be an issue. It's okay to leave it. How about fibular fixation? Well, it helps enable restore your length, your alignment, and rotation. So if you have an easy fracture, say you have a accommodated tibia, but a very simple, straightforward fibular fracture, take advantage of that. It's an easy reduction. It'll help you get the correct length, alignment, and rotation. And now, in some senses, I don't want to say soft bones, but it certainly facilitates everything you're doing. So here's an example. Here you have a oblique that I couldn't clamp correctly, but I had a reasonably straightforward fibular fracture that I just plated, and then went ahead and nailed it. The role of the AO distractor. So we've heard a little bit about this. I think it's effective. It helps you get your length, helps sometimes with alignment, but for me, I don't tend to use it unless it's a chronic correcting your length and alignment. But again, it's a good technique. I think if you're working independently, it's probably worthwhile. But in my hands, I tend to just use it in a setting where I need a lot of deformity correction because the injury is chronic and the soft tissues. I'm not able to overcome the soft tissue contracture associated with it. Okay, so pay attention to the posterior malleolar fracture that you often find this non-display, especially in spiral fractures. So if that displaces on you, it's going to be a very tough reduction. So I sort of think of it like styrofoam. If you put your thumb in styrofoam, and it's sort of a equivalent to what you have in the metaphysis there of the distal tibia. So if you push your thumb down or you displace it, you've already pushed bone out into where you would have a nice reduction. So recognize it, recognize the pattern, and then if you need to provisionally or stabilize it in a percutaneous way. So just to go have an example of, we'll address some of these issues we talked about. So here's a young male. He's got a segmental tibia with quite a bit of comminution distally. It's open. So, start with the easy reduction. For me, the easy reduction in this particular case was a fibula. So plate fixation there. I didn't have a plate long enough, so I just went ahead and did 2 plates. So, then at this point in time, I start with the nailing, but through my imaging fluoroscopic, I couldn't really address or assess, did I have it lined up correctly? So intraoperative flat plate, obviously I'm in varus, I'm 2 lateral. At this point, just blocking screw fixate or blocking screw to help me correct that. And you can see, I think I have the alignment in a reasonable position. So moving on to distal plating, the way that this really should be done is because it's a subcutaneous plate. You want to use a MIPO technique, and this is just one example of how you do that. But you can place your plate, you can anticipate where you're going to have your incisions for your plate, and then at that point use that MIPO technique. Now, do you need to do that? No, because oftentimes you can actually feel the hole, so you can just insert your plate and then there just go on to it your screw fixation. So recognize that these plates are pre-contoured, so you can use them as a reduction tool. So, and then secondarily, if again, just like the tibial nailing, you can use a fibula if it's an easy fracture to help you correct your alignment. Other considerations are using small fragment plates, especially if there's a complex fracture or there's another fracture you can get that's easy. So small incision in this particular case, posterior medially to help with a large apex, correcting that, and then using MIPO technique for the medial sided plate. AO distractor, again, another good adjunctive tool, but again, the only time I've used this is in the setting of a chronic deformity where I really needed to overcome the soft tissue contracture associated with it. In terms of a case example, so you can see that here you have a short segment with a comminuted fibula. Nothing's really straightforward in this. So I used to use a plate as a guide to really help me correct the deformity. So plate goes in, I provisionally pin it, and then I use a peritic or clamp to bring the fracture to the plate, and then from there on, just moving on with percutaneous screw fixation. So I appreciate it. Thank you very much.
My disclosures are in the manual, none really pertinent to this particular talk. So we're going to take up the torch here and talk about distal tibial nailing. And there's always like a macho thing, how low can you go? How distal a fracture can you nail? And well, you can do that, and that's pretty reasonable. Most of us in the room can probably do this, but the problem is really, should you be going this low? And so it's a question of insanity as to how distal you should try to nail some of these that become actually more amenable to plating. Because you can run into misadventures like this, typical deformity, or like this, where the nail broke, it's incarcerated, and a very distal malunion, non-union. If you look at the literature, pretty much they're all fairly in agreement within about 4 centimeters of the joint. They all do well, they heal, you can walk on them. But the paucity, or there's very little in the literature talking about extreme nailing. Below 4 centimeters, the only thing that's really consistent is there's a high rate of malunion, malalignment. So the key is, just like the other speakers have said, you have to get the reduction. The nail doesn't reduce it for you. The things particular to the distal tibia, and we'll go through this kind of in an algorithm with progressive complexity. How distal is it? How much comminution is there? What is the status of the soft tissues? Because sometimes that's a key. You may have to do a little more in terms of adjuvant fixation. Is there joint involvement? A lot of these have distal extension, even though it's non-displaced, but you have to pay attention to that. And is there an associated distal fibula fracture that may or may not involve ankle stability. And certainly, just like with proximal fractures, Samir talked about nail design. Certainly with distal fractures, there's a whole cadre of distal interlocking choices that you can picture or that you can choose, and they're all different. There's an effective, what I would call a capture area or cluster of distal interlocking screws that capture a finite portion of bone. And depending on which nail you choose, they're all different. So you have to match the nail to the type of fracture that you have. There's also a lot of manufacturers have fixed angle. They turn these distal locking screws into locked distal locking screws, and we'll talk about the pros and cons of that. And most of them do have biplanar locking screw stability. So here's what you have to choose from. And if you go down on the display floor, there's probably 40 more in differing configurations. But the key is you have to match the nail to match your fracture. So the first thing you need to think about is the status of the fibula. Is it intact? Because that makes a difference. Is the fracture, if it's fractured, is it comminuted versus transverse? And there's some different technical points that we can touch on that. We just submitted an abstract, and this was in very distal fractures with an intact fibula. Is this fracture at risk for non-union? They all went ahead and we nailed them. And basically we found that there is some prevalence to malalignment if we used a single distal locking screw. So the key of this study was you have to use two locking screws, and even if they're medial to lateral with the fibula intact, that was associated with malalignment. So with these very distal fractures, the upshot is you need to do biplanar interlocks, an anterior posterior and a medial to lateral, to avoid some of these unstable situations. Even with two medial to lateral interlocks, it didn't work out so good. That's very crucial. The articular involvement, as I mentioned, a lot of times it's a solitary fracture through the posterior malleolus, but oftentimes, unless you get a CAT scan, you may be horrified to find as you put the nail down, the thing kind of explodes in your hand. So I have a very low threshold for a CT scan. In terms of techniques, it's a continuum of tips. We'll start off with some simple things, and then we get more and more into the weeds in terms of techniques that you have to do. For the very distal fractures, I like the semi-extended or suprapatellar approaches for the simple reason that you don't have to flex and extend the knee. If you do the standard, bend the knee over the bump or the triangle, then you have to straighten it out. And the reason I like to keep it straight is it reminds me more of a pilon fracture. There's less chance of losing the reduction during the nail insertion, and it's basically a bit easier. So for the distal fractures, I've chosen to go to the more proximal approaches. Same starting point as was mentioned, but it's a suprapatellar or a patella reflecting approach, simply because I don't want to be moving the leg back and forth and losing my reduction. So there is some literature on simple articular reductions of the Seattle group, and we actually wrote a paper on this a number of years ago. That works out very nicely, but the key is you have to put the screws in first and then the nail to follow. So if there's any question, and this is from our old article, you get a CAT scan, you can see usually it's non-displaced, but the key is you have to reduce the fracture grossly, do a percutaneous or limited incision fixation with a front to back screw or a couple of screws, and then proceed with nailing. And here's a prime example of that, a spiral. It's usually the spiral, the fibula is intact, but you see the solitary fracture line out the back. So we fixed that first. You can see we barely captured it, but we compressed it nonetheless, and then we went ahead with the nail, and we'll get into this in depth now. So the reduction and the approach. For these distal fractures, there's very few things that I always do, but I almost always do this, and that's some type of a distraction for us. Samir talked about a femoral distractor. We published this a number of years ago, and instead of a femoral distractor, you just add a calcaneal tuberosity pin, but the pin at the proximal aspect is behind and above the fibular head, so it's posterior, so you can slide the nail in through a suprapatellar portal. You put this on, and then you pull on it, and you line it up, and then you lock it, and now you have this kind of portable traction device. And so for distal fractures, we pretty much do this without fail. Very simple thing to do, and you can go ahead and then nail an extension. And for the most part, your reduction is at least somewhat done for you. Now, the reason I like the medial and lateral bars, you could certainly use a femoral distractor as you see here, but I like to have this ability to apply, this is an Army Navy type retractor. And basically, if you put the bars posteriorly, you can use this as a reduction reduction aid. You can slide it proximal or distal, and you always have that posterior sag. So the first thing I do is I put the reduction, the 2-pin fixator on. I'll apply this Army Navy over these bars, as you see here, and I can reduce that posterior sagittal plane sag, or anticurvatum or procurvatum, if you will. So that's step one. Okay, and so there's a distraction CT scan, as you see. 2-pin fixator goes on first, and in this case, there's a little apex anterior. It's a very simple thing to put in a percutaneous Chance pin and then just lever it up, and this is very well described. You can go kind of medial, so you can avoid the neurovascular bundle. Put in a Chance pin. It actually can act as a blocking wire for your guide wire as well. You reduce that, and now your trajectory is set, and then you pop the nail down. So you start off a very simple, and notice the 90-degree spread, not medial to lateral. We try to get a 90-degree spread. The bicoronal, or excuse me, the 90-degree application of the screws. It's more stable. So you put your 2-pin fixator on, and then you proceed. Let's say you don't put the Chance pin in, but now you start off with your limited articular fixation. Proceed with your entry portal and your guide wire. And now this is another crucial area, is the ideal target area for your guide wire is more central and posterior lateral. The location of the ankle joint is the center and may be oftentimes overlooked, just like proximally. You may have a tendency to place that guide wire more medial than it is lateral. The tendency is to seat it too medial, which gives you a tendency for valgus and procurvatum. A really nice paper that was just presented yesterday and at the OTA demonstrating this, that if you put the guide wire more medial and anterior, you tend to induce a valgus and procurvatum. So pay attention to the entire plafond, not just this area here. You want to actually err. It's always a little more lateral than you think it is. Most of us tend to want to come in here. That's too medial, and you'll induce a valgus deformity. So put your 2-pin fixator on, get it out to length, and then put your guide wire in the appropriate location, seated more lateral than you think it needs to be, and also more posterior than you think it needs to be. And this is approaching the envelope here. We're below that top locking screw, so it's only good enough for 2 interlocks at 90-degree angles. Okay, so here we put the 2-pin fixator on. We've added our little malleable retractor for the sagittal plane correction. We're putting in our percutaneous wire for our front to back screw. Okay, and there's our suprapatellar portal, as you see here. So I do this all in the extended position. Now, I don't like the little recurvatum here, so I'm going to put in the little Army Navy and correct that in back, all right? And so again, just another example of that type of technique. A little more involved posterior malleolus that you see here. 2 screws, because on the CT scan it's fairly large, so we put 1 on either side of the proposed nail trajectory, and that's basically get the screws in once it's reduced, and then put the nail down. Now, we talked about the interlocking screws, and this was one of those particular devices that has locking screws that actually act as a fixed angle device. We wrote a paper. We're in the process. We presented this. We're publishing this. It's a problem. We had a high rate of non-union with distal fractures using this type of a locking fixed angle screw because it's kind of too rigid. Basically, we had no malunion, so our alignment was maintained, but we had a 50% delayed union and a 1/4 went on to non-union. And in all those fractures, we noted they routinely healed with minimal callus, and the non-unions were all atrophic. And so the thought here is that the construct is maybe too stiff, especially in this location, contributing to the non-union. And although we don't have proof of this, basically at this time we stopped using fixed angle locking screws for these distal fractures. We didn't have any problems with it before, and so we created a new problem by using this new technology. So I would recommend that you probably avoid that if you are still using it. So you put your fixator on and you got the screw in. Now, is it still mal-reduced? Well, your options are you can plate the fibula, you can use percutaneous clamps and Chance pins, and also, as been talked about, the mini position plates. We started doing it for open fractures right through the open wound, but have also recently started doing it for closed fractures. So what about plating the fibula? It definitely helps you reduce the fracture, but does it add to the rate of non-union? And that's been kind of the discussion. Does it increase the rate of tibial non-union? This year at the OTA, and actually a paper presented yesterday, various investigators have looked at that. You definitely get a better reduction, but both studies showed that the fibular fixation does not increase the rate of non-union after nailing. So if you're going to use it to reduce the fracture, that's tremendous. It helps you tremendously to help reduce that fracture. All right. So don't hesitate to go ahead and plate that fibula. So in this case, we put the frame on, we fixed the posterior malleolus. It still wasn't reduced. So we go ahead, we do some percutaneous clamps to try to clamp it in better position. Here you can see our sagittal plane correction. It fits underneath. You can slide it proximally and distally to reduce that recurvatum, that procurvatum. And here you see a case very similar to this where it comes down very distal, almost to the plafond, non-displaced, kind of an oblique type of a posterior malleolus fracture. So we put the 2-pin fixator on. You can see it's reduced reasonably well, but it's still in a tad bit of valgus. It's not great. So I wasn't happy with that. So now we put the guide wire down, and we're happy with the guide wire position, but not happy. So we go ahead and we plate the fibula. So that's the next level of complexity. Plate the fibula. Make sure your guide wire is seated more lateral, not in the middle, but a little more lateral than you think it needs to be. And at this point, we were able to nail it. And notice it's a little more posterior and lateral than you'd expect. And then the 3 out of plane screws. So that's the next level of complexity. Go ahead and plate the fibula or use percutaneous reduction techniques. In this case, the fibula was fairly transverse. We just could not get it reduced with just the fixator by itself or clamps. So we went ahead and did an intramedullary screw, and that lined it up very, very nicely. So if they're transverse, the transverse orientation, very simple to put. You could use a guide wire like Samir showed, or you could go ahead and use, I just like a 3/5 screw, very flexible, and it'll reduce it very nicely. Again, a little more distal encroachment clear down into the joint. As you can see here, the distraction CT scan is very helpful to elucidate that. Using more tricks in the book, again, the 2-pin fixator, the sagittal plane correction, a little reduction tool. We've plated the fibula. We still have a little translation here. I'm not happy, so we do a percutaneous clamp. All right, so now we're using more and more tricks available to us. And again, most importantly, make sure the guide wire is a little more lateral than medial, okay? And again, making sure you have your biplanar screws, and this one even kind of goes across doesn't go across the fracture because this is distal, but the extent of the fracture is right down below this screw. So it's a very distal type fracture, but appropriately using the locking screws where we're indicated. Again, a little more complexity with solitary migration into the joint as based on CT scan. So that's going to tell us where to put our kind of fixation screw. 2-pin fixator still didn't reduce. Plated the fibula still didn't reduce, but I can manually now shove this over. So this is just dying for our little sagittal plane reduction tool. Here you can see the retractor and a little oblique clamp, which lines that up perfect. All right. And then again, the almost crucial or the crucial part of making sure that guide wire is exactly where you want it to be. Again, this is a nice little trick to reduce that sagittal plane malalignment. You have to be careful to put your bars a little more posterior, but this will slide directly underneath this and you can flip it over and it sits very nicely. It really saves a lot of time. You can see there it is. And we've been able to seat the nail right down on the physeal scar. But it took plates, the fixator, and clamps to get that reduction. Now, what about the mini plate reductions we talked about? Again, they're smaller plates like Samir alluded to, the 2.7-2.5 mini plates. You don't strip anything. You just go in extraperiosteal fashion using unicortical screws. It's a reduction tool only. You're not using it for stability because the nail does all that work, but the nail doesn't reduce it. The plate does the reduction. So here's again another type, and this was a closed fracture. We had a tough time again because it was more of a proximal fibula. You just leave it in, and as they start to get callous, the patient weight bears. We just sent off an abstract. We looked up 46 of these, mini reduction plate through the open wound. We had 3 infections that were related to the open fracture, not necessarily to the plate. The upshot is a lot of these, we didn't take the plates out. The plates can be left in, they can be removed. You don't have to take them out. But basically, it helps you with the reduction. So do not be afraid to, if you still can't get it after the fixator, the clamp, plating the fibula, Step 4 is make a little incision, put a little mini plate on it. So again, provisional closed plating. Other investigators have looked at this. This was at the OTA. No difference in infection, malunion, non-union with provisional plating and nailing versus a standard technique. So if you do it correctly, you're not gonna get a non-union. You're not gonna get an infection. It's a very nice technique. Final technique is the blocking screws, so I won't really spend a lot of time. Again, think about it however you want. The nail wants to exit medially here, so we're going to block that with a blocking screw, so the concave side. Use blocking, I use a whole host of whatever. I use blocking screws, drill bits, K-wires, and chance pins. You block where the nail wants to exit. In this case, again, the nail is trying to exit medially, so that's what you're going to do. You're going to block that either over the nail or pull the nail back, put the wire in, put your guide wire back down, and then go ahead and put the nail in. It's added stability. It's very effective. So a simple blocking screw, you can see the nail wants to exit a little bit more posterior, again, inducing that recurvatum deformity. So we put a blocking wire. These are not really wires. They're 2.5 Kirschner, not Kirschner wires, Steinman pins. They're not K wires. They're fairly rigid so that they don't bend. I think Samir mentioned these things will kind of curve and bounce around. These are 2.5 Kirschner wires, so they're a bit more rigid than K wires. But again, the blocking wire goes posteriorly because the nail wanted to go more posterior than I was happy with. But again, excellent alignment. The nail is seated a little more perhaps lateral than you think it should, but again, we avoided that valgus deformity. Another case, the nail wants to seat more medial, so I put a Kirschner wire here to force the nail more lateral using our recurvatum correction and putting the wire in, as you see here. You kind of want to narrow the canal. I wasn't happy, so I put a couple more wires in, trying to enclose the trajectory. For whatever reason, the ones where the fibula is intact seem to be the problem children because they just won't move. I mean, you can put clamps on, and a lot of times you have to do clamps plus blocking screws or blocking wires. Here's a nice example. See the nail, the guide wire wants to exit more anterior. So this is my false passage. This is where I put it. That's way too anterior. The guide wire has to go in back of this. So we try again. We pull the guide wire back. We put the guide wire down. The nail wants to come out anterior. So we're blocking that passage now. It's translated that whole segment anteriorly. Likewise, the guide wire wanted to go too far lateral. So I'm putting a blocking wire on the lateral side to force it right about the center of the talus. All right. And so that's the construct. And then you drop the nail down. Now, what you have to be careful of if you're using wires, not so much with screws, if you spin the reamer on these, I've had the unhappy experience of having the guide wire go right out the back, come out by the Achilles tendon. So you have to just kind of push the reamer past that, because the reamer will spin those things and you'll advance them or you back them out. So just push it past if you so desire. Don't ream over those. And again, placing the nail in a very nice trajectory. We have room for all 3 screws in this situation, as you see here. Another case in narrowing the canal was fairly unstable, even with a fibula fracture. Using the blocking screws or blocking wires, and again, placing it where it exits. You can use chance pins, you can use screws. This is kind of a double whammy. We put the nail wanted to exit medially, exit posteriorly, so we put chance pins in, wanted to exit medially here. And so you can use these techniques up and down. All right, here's a chance pin we used, as well as screws. So really doesn't make any difference what you use. Everyone has their preference. The key is that you have to use them. Here we've kind of blocked it in and maintained our alignment. Selection of the nail is crucial. Again, matching the nail to your fracture pattern. All nails distally aren't created equal, so you really have to do a fair amount of pre-op planning based off your CT scan. There's not one nail for every fracture. As you see here, this is where we kind of erred. We plated the fibula. We had the 2-pin fixator on. Our seating area, our seating point was not quite correct, even though it looks pretty good. It's a little more medial than I've described and looked good intra-op, but you can see the true center is here. And so the patient is in a little procurvatum and some valgus, not a lot, but that's the way it goes, not done pristinely. So that central seating point is very crucial when you finally seat your guide wire. Now, for a patient like this with that much soft tissue, you have to probably use all techniques, throw in the kitchen sink. So remember all these techniques. If you want to take one picture, take a picture of this slide, because the combination of the spanning X fix, the suprapatellar or supra extended nailing, fibular plating, pert clamps with percutaneous pins, mini reduction plates, and blocking screws. Those are everything that you need. In this case, we pretty much use all of those. 2-pin fixator lines up kind of okay, but not great. We got a little bump here to try to reproduce the sagittal plane. Plated the fibula, still a little bit of a translational effect. Did some percutaneous screws for the articular involvement. Used blocking screws to seat the guide wire right again posterior and a little more lateral. As you see here, the blocking wires, and then put the nail down. This is a 2-year follow-up after we took the locking screws out. Again, compared to that previous case, it's lined up perfectly, and you can see the distal extent of that fracture. The other trick you can use if you have osteoporotic bone is once you get your guide wire down and you've reamed, exchange your bulb tip for a sharp guide wire once your trajectory is achieved. Then you can actually impact that nail right into that distal cancellous bone below the physeal scar. That's very helpful for osteopenic or osteoporotic because the best bone is right at that physeal scar, and it acts as another point of fixation if you're worried about your locking screws. Hippocrates had a nice little discussion on this with an open distal tibia. He said it's basically futile. Let's not even treat it because the patient will die within 7 days anyway. So just make them comfortable and away we go. So I think we've come a long way since that time. Remember, successful nailing is a combination of all techniques. Every trick in the book you kind of have to throw in for that. So above all, do what you do best. If you're a plater, then go ahead and plate it. It's not a sign of macho-ness to plate a distal fourth fibula or distal fourth tibia if you're a good plater. So thank you once again.
Hi, my name is Jody Siegel, and I'm going to talk about pearls and techniques in tibial nailing. My most important disclosure for this talk is that I'm a nailer, not a plater. So with every tibia fracture that I see, I'm trying to figure out a way that I can nail it. Classically, tibia fracture nailing was originally described through a hyperflexion technique. Through a medial parapatellar or medial paratendinous arthrotomy, the knee was accessed. The patient's knee was hyperflexed to allow for the nailing and the instrumentation. This led to challenges with fluoroscopy, as we all know if you've ever done a hyperflexion tibial nail. For mid-diaphyseal fractures, this was probably not a big deal, and that's how it was originally described. But as we've evolved to nail more proximal and distal fractures, we've recognized the challenges with hyperflexion tibial nailing. Originally, we recognized this with proximal fractures. This is because they're simply hard to nail. The proximal tibia is wide, the nail is narrow, the canal is narrow, the fluoroscopy is difficult, and we know that we must have a perfect portal in order to have a well-aligned tibia. The problem in tibial nailing is valgus. That's because the canal sits along the lateral cortex. We know where the portal should be, but if your portal drifts a little bit too medial and then you try to nail the tibia, you're going to end up with valgus malalignment. If you get the portal in the right spot and you stay in the right spot and you put the nail in, then you're going to have a straight tibia. In the sagittal plane, the difficulty is typically with flexion. This is commonly what a fracture can look like, and it'll be accentuated whenever you hyperflex the knee so that you can get the instrumentation in. The patients will be unhappy. And this is the classic x-ray that happened after hyperflexion tibial nailing in proximal fractures. Additionally, the old portal was originally described as anterior. This allowed for a lot of posterior fallout when attempting to nail. The newer portal was described as more superior, which was in line with the shaft, which caused less issues with tibial nailing in the sagittal plane. This sweet spot raised concerns about being within the meniscus and hurting the anatomy inside the knee joint, but was also looked at in a lab and found to be not within the meniscus. Radiographically, the perfect portal is just medial to the lateral tibial spine in the coronal plane, again, because that sits just over the canal, which runs along the lateral cortex, and it's adjacent to the joint in the sagittal plane. So with the issues with hyperflexion tibial nailing, we started to look at other ways that we could nail to avoid some of these problems. The semi-extended technique was introduced by Dr. Tornetta about 25 years ago now. And it was originally described to nail proximal fractures due to the deformity that he noticed in the sagittal plane with the hyperflexion. Additionally, we've all figured out that nailing in this position makes the fluoroscopy significantly easier. And we've evolved over the years to make our skin incisions smaller, because these were originally done through large incisions that are a lot like total knee incisions. But what we need to remember is the semi-extended technique is still done through a medial parapatellar arthrotomy. You need to be able to subluxate the patella laterally out of the trochlea so that you can protect the joint and get the instrumentation in. This is different than the suprapatellar nailing, which is done through the quadriceps tendon and underneath the patella, which introduces different difficulties, which I will touch on. With the semi-extended technique, we all know that the fluoroscopy is significantly easier. You can move the C-arm to get traditional AP and laterals, which allow you to get the perfect AP and the perfect lateral so that you can make the perfect portal. Additionally, it helps with the deformity that we saw in the sagittal plane, which was the reason for its original introduction. The portal location, again, in the semi-extended technique is the same as it is in the classic hyperflexion technique. It's easier to get, and with the knee flexed, you can actually access it. Again, just medial to the lateral tibial spine on a perfect AP image. It's important to look at the tib-fib overlap on your fluoroscopic image, because if you don't have the perfect AP, then you're going to find that your portal is actually more medial than you think it is. You must be above the canal, which runs along the lateral cortex. Reduction is obviously everything in fracture care. For tibias, the perfect portal is important. Good visualization of the portal and the fracture is important. And then you also have to understand the anterior angulation and the posterior translation, especially in nailing proximal tibia fractures. And then this helps me with my next steps in the operating room. I take a lateral image in flexion and I look to identify whether there's any anterior angulation, which I can handle with the semi-extended technique. But it's also important to look and see if there's any posterior translation, because that's going to require some blocking screws. Simply using the semi-extended technique won't help with that. And then obviously, if I have both of these problems, I will have to do both of these things. So in the lateral view, with the knee extended, I see that the fracture is well aligned. If I flex to approximately 30 degrees, I might lose a few millimeters of translation, but the patient won't notice this. This is also one of the key differences between semi-extended and suprapatellar nailing. Suprapatellar nailing is done with the knee in extension, and the proponents would say you don't lose those couple millimeters of posterior translation. However, it's difficult to access the portal because without any flexion, if the patient has intact ACL, it's hard to subluxate the tibia anteriorly to get access to the portal. So with 30 degrees of flexion, it's easier to get access to the top of the tibia to obtain that portal. So in the lateral view, this is a pretty good x-ray. Here's the instrumentation sitting on the trochlea. Here's the fracture reduced, and everybody's happy. Now, blocking screws were introduced by Credit and Cole probably 25 to 30 years ago now. Their entire purpose is to tighten the canal or block the position of the nail. I know that my residents like to talk about placing the screws on the convex and the concave sides, and I find all of that very confusing. I like to simply think about it as I put the blocking screws where I don't want the nail to go. They are literally blocking it. And when I think about it that way, I get less confused. So remember, again, the problem with tibias is valgus, and you can use blocking screws in the coronal or the sagittal plane to help with your deformity. So we know where the perfect portal is, and we know that gives you a straight tibia, and then everybody's happy. But what we also know is that a lot of portals drift medial, and then you get crooked tibias, and nobody's happy. So to fix that with blocking screws, you have your medial portal, which you don't like. You want to prevent the nail from going laterally, so you put in a blocking screw. Re-ream, hit the blocking screw, shifts the tibia, and you end up with a straight tibia. This will cost you a few millimeters of translation, which the patients aren't going to notice and they don't care about. They do not like angulation. They cannot feel translation. So again, the principle is to prevent the passage of the nail into the bad spot or to tighten the canal. In the sagittal plane, this is also helpful, especially in nailing proximal tibia fractures, because it prevents that posterior fallout. It allows the nail to actually go down the canal and keep the tibia straight. This is classically where the blocking screw would go to help in the sagittal plane deformity. So here's the classic example. Here the portal has already slid a little bit anteriorly. You can see that the tibia is shifted or translated posteriorly into an unacceptable position. It's probably going to cause some soft tissue compromise. Here's the passage of the nail. It's difficult to maintain the alignment. Once the nail hits the blocking screw, the alignment is improved. The soft tissues are happy. The tibia is straight. Everybody's happy. I also have some other tricks that I like to employ with some of my tibial nailing. I think unicortical plating is a very valuable tool. I don't have to use it very often, but in certain disaster situations like this one, it can be quite useful. So this motorcycle guy came in, has this fracture and a lot of other things going on proximal to this fracture. Terrible soft tissue injury, as you might expect when your tibia looks like this. He came in and when one of my partners was on call, and he had the idea to use the unicortical plating to help provide some stability initially. This is what it ultimately looked like. He was obviously in traction for his more proximal injuries. And I left these unicortical plates on whenever I inherited him and ultimately took him back to nail his tibia. I left the plates on as long as I possibly could. Most of the screws were not in the way. And then I got this result. It's not perfect, but given the original injury, I was happy. And then 18 months later, this is what this patient's x-ray looks like, which I'm very happy with. He does have a diaphyseal non-union, which he has elected at this point to not do anything about. Here's another example of a unicortical plate, significantly younger patient, terrible sagittal plane injury, which I ended up finding to be very unstable. I struggled with holding the reduction. And then ultimately I employed some unicortical plates and then left the plates on, and this kid went on to unite. Other tricks that I use are lag screws. We've been doing this for years around the nails proximally and distally, and more recently intracortically. Lagging the joint is pretty common, and we do it with plating all the time. So why can't we do it with nailing? Well, we do. So here's a classic example of a proximal tibia fracture, which extends intra-articularly in another one of my motorcycle patients. The important thing about lagging before you put the joint, or lagging the joint before you put the nail in, is to understand where the nail is going to go and then template around it. So we know where the perfect portal is going to be on the AP and on the lateral. And there's a lot of real estate in the proximal tibia where you can put the lag screws. This is what his joint looked like. So I reduced the joint, put the lag screws in, not in the way of the nail, have the classic deformity that you can see with the translation in the coronal plane. Then here's the instrumentation and the nail going in. It's also important to know where you need to seat the nail. In extreme nailing, an important principle is maximal nail in the short segment. I would rather have had the nail sit a little bit more proximal to use the subchondral bone as another point of fixation, but I wanted to get all of the proximal locking screws in through the nail, so I had to seat the nail a little bit further just so I could get them all in. It's important to understand that and make that decision consciously for what you're chasing after. And this is ultimately what his final x-ray looked like. And he went on to unite his fracture, and I was happy with his alignment. Same thing with distal nailing. Now I look at this fracture and I see if I have to plate that, it's going to take up 2/3 of the length of the tibia, and I just can't put a plate on 2/3 of the tibia. It makes me queasy just thinking about it. This girl came in with an open injury at one of my partners spanned for me. She had a defect in her joint ultimately, and this is what her joint looked like. You may again be thinking, that is crazy. How are you going to nail that? Or why would you even want to? Well, again, I hate tibial plating, so I opened it. Just because you nail it doesn't mean you can't open, reduce something. I put a bunch of clamps on, got her well aligned, put some small screws to stabilize the joint, and then nailed her. And I'm very happy with how this x-ray looked. And I saw her a couple of years out complaining about something else, and her ankle motion was still pretty good, and she didn't have any pain yet. So what other types of lag screws are there? Well, there are intracortical screws that have been used in the diaphysis, which people have been doing more recently. It's important to remember that these are in hard bone. They're cortical screws. Here's an example that one of my partners did. That's a large butterfly fragment with a coronal split that had good soft tissues attached to it. So ultimately, initially, that he saved that fragment and put in some intracortical screws, and then later went back and this patient got nailed at the time of his soft tissue coverage procedure. It's just important to remember that the bone in this area is hard. So here's another example. This is a cortical butterfly split fragment with good soft tissues attached to it. Nobody wants to throw that away. So instead, you can just reduce it and then put small or mini fragment screws all in the cortex. Remember that this is in the diaphysis, so there's not a lot of real estate to so-called put screws around the path of the nail. The nail is going to take up that entire canal. So you can put them entirely intracortical. Here's an example of a patient of mine, similar type fracture pattern. Got that large cortical piece reduced and some screws around the nail. And then somehow that ultimately went on to unite. Here's one of my favorite patients. He came in on a weekend and was waiting for me on Monday morning. If you look at this fragment, this is a closed injury, and that fragment is flipped 180 degrees the wrong direction. And I'm thinking to myself while I'm laughing, that's a terrible problem. But since it's Hip Fracture Monday, I'm just going to fix a bunch of hips and leave this for one of my partners. Of course, my luck, there's no hip fractures and I'm stuck with it. So what am I going to do with that piece? I don't love it at all. Well, I did what I always do. I had to make an incision that was large enough that I could actually reduce it. So I reduced it and clamped it and then nailed it. And I needed to give some stability to the fragment and hold it into the reduced position. So I also put in some mini fragment intracortical screws. And this guy went on to heal uneventfully and was very happy. I will warn you about these screws is that they are all in the cortex, in the diaphyseal bone of the tibia, which is very hard. And these are mini fragment screws. It's very easy to pop the heads off. If I can do it, anybody can do it. I beg you to use the tap. The taps are in the systems. You may not have used one in a long time, but you really need to use them here. You can also countersink if you're worried about the heads being too prominent along the medial tibia. And other tricks that I have may not be tricks, but don't be afraid to use them and just think about them. I use clamps a lot, and I also use my knife a lot. I'm not afraid to make an incision. I think the classic way to think about this is in those distal third spiral oblique shafts, the ones that get a lot of press nowadays for being associated with a posterior malleolus fracture. I think there's a lot of controversy about how much is acceptable for the gapping or the translation of these fractures. I can't stand looking at that, so I just clamp and reduce them all. So I use the traditional shaped Weber. The fragments of the tibia are always posterior lateral and anterior medial. I make percutaneous incisions. I slide under the muscle for the posterior lateral tine of the clamp and then just poke in anterior medially, and then I reduce it. And then I go about my typical nailing. This is an example of that. Typical distal third spiral oblique tibia. I reduced it and held it in place with the clamp and then made it a sawbones tibial nailing. And this is what it looked like afterwards. So in summary, for tibial nailing, portal is everything. We know we need a perfect portal to make the tibia straight, and all fracture care reduction is also everything. So I employ whatever technique I need to do to make the tibia straight. I like to nail in the semi-extended position. I use blocking screws for posterior translation, and anytime the portal is bad, I'm not afraid to percutaneously or open clamp things. I use unicortical plating when I have to, and I use a ton of lag screws because I like to make my joints and my tibia well aligned. Thank you.
Hi, Jack Wickstead from Boston. Beth Israel, back with you talking about open tibia fractures. Sad to say that my dog abandoned me on this talk. I guess I'm not the most dynamic speaker in the world. Anyway, bear with me. Appreciate your time and your interest. So we're going to talk about open tibia fractures. I was tasked with giving an update on this. So we'll get right into it. I have nothing to disclose. Of course, my disclosure, my faculty's disclosures are all available on the AAOS website. Here's the objectives that we're going to talk about today. You know, this is supposed to be an update talk, but I wanted to touch briefly on what we already know about open tibia fractures. There's a lot of data going back many years that tells us, you know, largely how to take care of these patients. There should be no mysteries here. So we're going to touch a little bit on what we already know. And then we're going to review briefly what we can say is new about treating open tibia fractures. And then lastly, I wanted to finish up with sort of, you know, practicalities. What's a reasonable way to approach these tibia fractures on a day-to-day basis? You know, how can we take what we know about these injuries and just, you know, reasonably approach them so that we get the best possible outcome for our patients? All right, and I'm going to hang my talk really around this case. This was a 26-year-old, sort of typical motorcycle crash that comes in late at night, you know, and a 26-year-old laborer. All right, so let's talk first on my first objective, open tibia fractures. What do we already know about them? Well, first of all, we have to pay attention to the basics. You know, these injuries are associated with high rates of complications and they have lots of problems, particularly compartment syndrome. It pays to get engaged in the patient's care right off the bat. IM nails really remain the first treatment option for these patients, and they can be safely used in most open tibia fractures. And then lastly, early coverage gives excellent results. We can say that definitively. How early? The earlier, the better. So let's start with each one of those items in turn. First of all, pay attention to the basics here. This is a nice trial looking at type 3 open tibia fractures. Immediate antibiotic prophylaxis minimizes infections. We've known this for a lot of time, and this data just backs it up. Independent predictors of infection were wound coverage beyond 5 days and antibiotic treatment beyond 66 minutes. These patients need their antibiotics. They need them early. They need flap coverage. They need that early as well. How do we do on my 26-year-old guy, the case that we're sort of running through here? Well, antibiotics, he got en route. Patient was able to recall the event of flipping over his motorcycle. He took his helmet off and called EMS himself. And then when EMS arrived, they found that he had an open right lower extremity wound and gave him ANSAP en route. Hard to beat that, so he definitely got it within 66 minutes. How about coverage? We got him covered. Again, came in on 9/17, and by 9/20 was covered. I try and get everybody covered within 72 hours. We've gone to the extent of actually hiring a plastic surgeon to work in our orthopedic department. Doesn't work for the plastic surgeons, doesn't work under general surgery. He's one of us. And we hired him to do part-time hand and part-time flap coverage for us. So he's in the orthopedic department to get these kind of cases expedited. We know these patients have high rates of complications as well. This is a nice paper by Lisa Canada looking at segmental tibia fractures. Now, arguably, this guy's not segmental, but in Lisa's series, 73% of her segmental tibias were open. 31% of these patients got compartment syndrome. So high rates of complications. Engage in these patients early and be aware of those complications and try and head them off before they start. Compartment syndrome gives you a very narrow window to take care of that patient. And if you wait until the morning to determine whether or not they've got compartment syndrome, it may be a little bit too late for you. This is my 26-year-old patient when he comes into the trauma bay. High rate of compartment syndrome in this guy, and we can tell within the first 30 seconds that he is going to need a free flap. So we can start the wheels rolling on getting him organized for a free flap right off the bat. All right, how about nailing open tibia fractures? Here's a nice trial by Paul, reported in 2007. Open fractures of the tibia, immediate intermedullary tibial nail insertion. Deep infection rate was 3%. There's no problem with treating these patients as long as they're adequately debrided, soft tissues are handled appropriately with immediate nailing. Now, in this case, I know he's going to need a free flap, and I'm a little bit worried about the amount of gap that I've got present once I start taking out, dead and devitalized bone. So his treatment plan was a little bit circuitous, but did wind up with a nail. We'll go over that a little bit later. Lastly, in terms of what we already know about tibia fractures, we know that early coverage counts. Here's a nice trial looking at type 3 open tibia fractures. Again, immediate antibiotic prophylaxis. Wound coverage beyond 5 days was an independent predictor for infection. So you've got to get these patients covered, and you've got to get them covered quickly. All right, so that's what we already know about tibia fractures. What about new? What can we say that's new and different about treating open tibia fractures? There's been some data coming out in the last few years that I just wanted to review. First of all, the FLOW study made a big splash. 2015 was presented at the OTA and simultaneously released in the New England Journal of Medicine to much fanfare. 2,500 patients were treated open versus closed, Castile soap versus standard saline, high pressure versus low pressure. Reoperation rate was similar regardless of irrigation pressure. So it didn't matter whether you had high pressure or low pressure. Interestingly, the reoperation rate was actually higher in the soap group than the saline group. So standard plain old saline, high or low pressure doesn't make any difference. All right, so the FLOW trial, again, 2,500 patients, pulsatile lavage versus low pressure irrigation, no difference. And saline preferable to Castile soap solution. So just use plain old saline in those. How about will my open tibia fracture heal? I don't know who else is using this score, but I love it. It's the nerd score. Like, who's not going to love the nerd score? We're orthopedic surgeons. Of course, we have a nerd score. This was a predictive study that came out of shock trauma. They looked retrospectively at over 900 tibias. Of course, like any orthopedic surgery trial in trauma patients, a third of the patients didn't follow up. So the data is a little bit suspect in terms of the fact that a third of these patients didn't show up for follow-up. So we can't really say whether they healed or not, and that may have skewed the results of the study. But nonetheless, basically the NERD score was a way of dumping patients into one of four buckets. And they assigned, this was a multivariate analysis study where they looked at, who healed and who didn't heal and what the predictors were. And then they went back and assigned them a score, and you get, certain points for certain effects. So if you got a free flap, for example, you got 5 points. If you got compartment syndrome, you got 4 more points. If you had open fracture, you got 2 points added on. And the more points you got, the worse you did. So if your NERD score was over 12, so for example, you got compartment syndrome and you had a flap and it was open and you were a male gender and you had diabetes, well, you're going to be way over 12 here. Your non-union rate was 61%. Whereas if your NERD score was very, very low, less than 5, if it was a closed injury, if you didn't need a flap, if you didn't get compartment syndrome, then your union rate was quite high. And of course, your predictability was much lower. This is just sort of useful information for you to share with your patient about, it allows you to organize what their risk factors are and how severe they might be. So I think probably a lot of people aren't using the NERD score, but it is new. And I wanted to throw it out there because, hey, we're all nerds, right? Some of us more than others. All right. How about LIPUS 2016? We're moving up the, we're into 2016 now. What about LIPUS? This was a randomized trial of 501 patients. Postoperative use of LIPUS after a tibia fracture did not accelerate radiographic healing using the RUSS score. This was the TRUST trial. 501 patients, LIPUS not effective. In my own practice, I found myself using LIPUS from time to time just to stall the patient. Like, I don't really want to do anything, and I need to give them something to do. And I'm not sure that's really worth a $3,000 bone stimulator that's been proven not to be effective, particularly in tibia fractures. So that's new on tibia fractures. LIPUS not effective. Unreamed versus reamed nails. What about that? That's an issue that we keep fighting over from time to time. This is sort of, I would say, the definitive paper that came out in 2017. Reaming did not affect functional outcomes after open and closed tibia shaft fractures. Really no effect for the reaming. And when you look at the graphs, they're all overlapping each other. Interestingly, I think what we really can take out of this paper probably doesn't have anything to do with ream versus unreamed nails. I think what we can take out of this paper is that patients with tibia fractures really do crappy. We know they do crappy, and we tell the patients they're going to do crappy, but this is objective evidence that shows that their SF36 scores here out to a year are really fairly significantly lower than what you would expect at baseline. So really, open tibia fractures really doing quite poorly relative to baseline norms at 1 year, and that's useful information for the patients to know. How about circular frames? This was data that was just presented at the OTA. The metric collaborative looked at ring fixator versus a standard fixation for open tibia fractures. This was the FIXIT study. Major complication rates in ring fixators were 62%, and major complications in nails, 42%. So ring fixators had significantly higher complication rates. The proposed benefit really of ring fixators was to limit the deep infection rate. But when you looked at the data objectively, there was no real difference between the deep infection rate in external fixation versus internal fixation. So ring fixators kind of take a little bit of a knock here in 2020. Okay, so that's what's new about treating open tibia fractures. And then lastly, my last objective, I wanted to talk about, what's a reasonable way to approach these fractures on a day-to-day basis? First of all, let's start with the basics. Make sure these patients get seen by the trauma team. ATLS still counts. These patients need antibiotics early. Cefazolin plus or minus gentamicin is what we do in my institution. Those patients need their antibiotics within an hour of their injury. The sooner they get it, the better. In terms of basics, intermedullary nails work well. Other forms of thoughtful, careful well-planned surgery also work well. Nails are the mainstay for these. If you've got a good reason for doing something different, as long as you've got a good plan in place and you are actively engaged in the care of the patient, it's probably going to work out well for you. But being actively engaged in the care of the patient is really the critical portion. And then lastly, I would make, again, a pitch for timing to coverage. The sooner these patients get covered, the better. In our institution, our goal really is 72 hours. My rational approach to this is, in terms of fixation, when these patients show up, here's my 26-year-old guy in the trauma bay, big, huge hole. I know he's going to need a free flap. The fixation is what matters least to me. I can deal with the fixation. I put lots of hardware into lots of tibias. That part's not the complicated part. It's the coverage that counts the most to me. So I decide immediately, if they're going to need a flap of some sort. And my first call is not usually to the operating room to book the case. My first call is to my plastic surgeon to say, look, I've got this kid. Here's what his leg looks like. He's going to need a flap within 72 hours. I need you to cancel whatever it is that you're doing on Tuesday to get this done for me. And we have a good working relationship with our plastic surgeon, and they know that when these cases come in, things are going to have to move around for them. So my first phone call really on these patients is oftentimes to the plastic surgeon to start planning that first 72 hours. Again, the fixation is what the fixation is. If I can nail it immediately, fine. If I have to put it in X-Fix, fine. What I'm really worried about is the coverage. And then I base my treatment really around that coverage. What's he going to need for flap coverage? How am I going to be able to avoid infection in these cases? Here's my 26-year-old motorcyclist again. The night he comes in, I put him in a temporary external fixator, right? I decide right away that he's going to need a flap. I call my plastic surgeon. If you don't have a plastic surgeon or you can't guarantee that the patient's going to get covered within a quick period of time, don't take care of these patients. Transfer them to somewhere where they can get the care that they need. It's quite clear that patients need coverage. And the data would say within 5 days, coverage after 5 days is an independent predictor of deep infection. If you can't provide that kind of coverage, don't take care of those patients. Get them to someplace that can. Most open fractures can wait to go to my trauma room in the morning. I'm in an institution that supports me with a trauma room in the morning. Most of these patients can wait, 8 to 12 hours to get into the operating room. That's not the problem. What they really need is early antibiotics and early coverage. That is independent of whether I operate on them at night. That being said, I will always try and do the right thing for the patient. And if you look at the leg and think, what's the right thing to do here, then obviously you'll do it. So in this case, I came in that night and washed the guy's leg out. I'm not going to leave that laying around till the morning for my, junior residents to keep an eye on. My plastic surgeon gets a text message at midnight, and he texts me back in the morning, and we decide on his flap date right then. So he gets a temporary X-Fix and a VAC. At 48 hours, I bring him back to the operating room. I'm not doing a repeat washout. I've adequately debrided this and taken out a bunch of bone already the night that he comes in. I'm bringing him back at 48 hours, not for repeat washout, but to primarily shorten him. I find the easiest way to get rid of a segmental defect or a big gap is to just shorten patients. And I use some judicious lag screws to, take the pieces that I can save and, just judiciously lag them into place. Limited amount of hardware. I'm going to put a simple frame on here to make it easy for my plastics guy. And then he gets flapped on day 3. So I convert him to a ring fixator a couple of weeks later. And again, this is, you'll see on my x-ray here, I put a little plate in here. When you're primarily shortening people, they have a tendency to, spring back open again. You push them back together and it looks great. And then they just want to spring open. And a little small plate here is a great way to keep them from springing open. I'm trying to keep this very, very light on the hardware. And then when I'm sure that my flap is going to take and 6 or 8 weeks down the road, when I'm sure that the patient doesn't have a deep infection by this point and the flap is taken nicely, then I can go ahead and nail the tibia. So, here he is with his nail in place. I can, fish out those lag screws in that little bitty plate. I had put a little cement spacer in there. I bone grafted him. Here he is at 6 months and here he is at initial presentation, and here he is at 1 year. Again, that framework was always designed to be temporary until we could be sure he wasn't infected, and then I put the nail in. So here he is, but he does have a 2 centimeter leg length discrepancy because I primarily shortened to get rid of the gap. But he's back to full-time laboring, and we're talking about whether he wants to get lengthened or not. So in summary, the basics really matter the most here. Antibiotics, debridement, coverage, alignment. Stick with the basics and you'll do fine. What's new? Well, soap, no, don't use soap. Lipus, no, we're not going to use that either. How about reaming? Maybe you don't really have to ream either. What about circular frames? No, circular frames have higher complication rate. All this stuff is getting thrown out. So again, stick with the basics and you'll do pretty well. The one point I would say is to make decisions about your flap coverage early. Don't screw around with these guys. Put a flap on early. Don't put a vac on, bring them back in 3 days for repeat washout, hem and haw, decide whether or not you're going to need a flap, bring them back 3 days later. You've already missed the boat on those guys. Decide when they first come in if they're going to need a flap. And if they do, get them, if you don't have that ability in your institution, get them out of your institution to someplace that can flap them. And don't try and compromise on the flap coverage either. We have this tendency to try and avoid free flaps. Damaged local flaps will fail. If the gastroc and the soleus are right in the middle of the zone of injury, they're not going to do well. Those patients need free flaps, and that can be done at plenty of places. So have a rational plan for taking care of these patients, engage in their care early, stick with the basics, and most of these patients will do quite well. Thank you.
Lower leg injuries. So I'm going to talk a lot about really basic management. We won't get into surgical details much at all. I'll allude to them. And I'm going to try to cover in the time the tibial shaft, the fibula, the distal femoral, the distal physes of the tibia, and then some foot injuries. Let's start with tibia fracture. So I would argue that the tibia of almost everything we take care of has the biggest range of potential problems. So they start out, some of them are just the easiest, most simple toddler's fractures, all the way to these. So if your tibial algorithm is probably, in my mind, the most complicated one of all the ways we manage our fractures in kids. So most tibial shafts are treated in casts. Most of them are relatively straightforward. However, lurking in the weeds with tibial shaft fractures are a couple important things to remember. And it turns out they are the most common places we see compartment syndromes and the most common places that we see open fractures in children. So let's start with evaluation. One of the first, actually the first fasciotomy I did as an attending was a child who came to the clinic after an injury on the Wildwood Boardwalk in New Jersey. Okay. She slammed into the slide. She was on the slide, slammed in, had a non-displaced fracture, seen at a local ED, transferred to us for care the next day. And she had a raging compartment syndrome. So these show up to your clinic. So you have to be thinking about it. Always ask about the mechanism, the timing of the injury, whether there was deformity that now was reduced. The bleeding thing. So remember that little bit of brown sort of spotting that people sometimes call an abrasion sometimes is a grade 1 open fracture. So pay attention to that. I always ask, was there blood at the scene? And ask them to explain it to me because it changes your management. If they can weight bear or not is another thing. So a lot of those non-displaced tibial fractures with an intact fibula, they sometimes will just limp in. They won't have an inability to walk. And then talk about pain. And we'll go through compartment syndrome because I think it's something that's important. So the P's of compartment syndrome, everybody learns is one of the first things as a medical student on an orthopedic rotation. But as we are all aware, on a paper that still, I think, is one of the most important things that pediatric orthopedists know is that the P's are unreliable. Right. What we need to pay attention to is really the idea of this increasing need for analgesia, the anxiety and the agitation that you see in the clinical diagnosis of the clinical setting. So yes, I do go through the P's, especially if they're over 5, because you can almost usually get a reliable exam on them. But if they're little, especially, you're not going to be able to tell if they're having paresthesias or what that even means to them. So you have to pay attention to the other details you can look at. So I really want people to remember this. So always think of it as first of all, it's a clinical diagnosis. And then you ask the 3 A's. So the A's are this concept of anxiety, meaning they are totally unable to be consoled. So as you know, children, even the most injured children, if they can be consoled, you're much more happy that it's not this evolving. Agitation is the idea that they can't sit still. I don't know if you've ever seen a child who has a compartment syndrome, but they don't lie stiff. They do the opposite. They're always writhing, moving around. So those, and I'll tell you what I do. when they're admitted to the hospital, I will watch them from the outside of the room first before they know I'm there to get a sense of what they're really going through. And then, of course, you then go to the medical record and you ask the nurses specifically how much pain med they have been given. And you say to me, well, shouldn't you know? Weren't you the doctor who gave it? Well, not necessarily, right? You might get a nurse who asks another resident on call. Or in our system, we used to have pediatricians cover at night. So sometimes we would come in and not know that the child had been given increased pain medicine. So pay attention to details. And then the other thing, we do know that children's compartment syndrome is different than adult compartment syndrome in that even if we get to it a little bit late, they tend to do very well. So if you're still on the fence and it's 24 hours after an injury, you go and still do fasciotomies, okay? The kids do much better overall than adults in general when they have compartment syndrome of the tibia. So again, if there's a chance that I can save muscle, then we will just go to the OR. Open fracture care in children is basically antibiotics and the ED seems to be the most important thing to prevent infection. Okay, it's not the only thing, but antibiotics and the ED, and then ideally an IND of the spot within about 24 hours. We could debate all day about whether grade 1 open injuries in the upper extremity need to go to the OR, but in general, a good rule of thumb is antibiotics and the ED and consider going to the OR within 24 hours, okay? When you're doing your post-op care, so let's say you have a surgeon you work with, you're doing post-op care, they can get infections and they can get non-unions as a higher rate in the tibia in particular. So pay attention to that part as well. So tibial shaft fractures in general, let's just go straight forward, cast immobilization. So we tend to use a long leg cast first and then mobilize them. And I tend to make them non-weight bearing. Now, there's some data to say that you can let them weight bear on certain fracture patterns in certain ages, okay? But I tend to use a long leg cast in the first 3 or 4 weeks, non-weight bearing. I'll do serial x-rays. Your point about the question about when to re-x-ray them. So the tibial shaft, you can move around probably within 3 weeks or so, just do closed manips. So if you ask them to come back in 5 or 6 weeks, you have to do something open or something in the OR. So I will see them in that short period of time. Cast wedging this is probably the best place to do cast wedging. Okay. And again, it can be done as long as you think you can move this thing around. Cast wedging works best in single plane deformities that are less than about 15 degrees though. It's really hard to get 2 planes. It's impossible, of course, to get rotation. So if you're off in rotation, I think you got to change a cast. Acceptable guidelines for the tibia, less than 10 degrees of angulation, less than 2 centimeters of shortening. And translation, I will take in younger people because they will remodel it. It looks terrible if it's translated anteriorly in an older person, though it's a big bump. So I tend to be less likely to take that, but if it's medial-lateral, I usually will take it. And remember, less than 10, rotational malunion does not remodel, and overgrowth is unpredictable. So don't accept a lot of shortening, assuming that it's going to do what the femur does with overgrowth. It doesn't in the tibia. So again, these are the fibula being intact is actually more common than not, and they're the easiest ones to manage, although occasionally they'll drift into varus, not in this case, but they will drift into varus. David talked about the bad actor, the Cosen's fracture. And we all see these. We talk about trying to reduce them. If you're going to reduce them, you have to put them in extension to get the knee in, to get a little force to get them out of valgus. So it's not so easy to do. And I can tell you, even ones that looked non-displaced still can do the Cosen phenomenon. So I see all of them back. And it's the first thing I say to them after I say we're going to heal this fracture, it's going to be fine, is, oh, by the way, there's a chance your child's going to be knock-kneed for a little bit and it'll get better. So who are the ones that shouldn't be casted? So there are really some difficult problems that are difficult to manage in cast. These are open fractures, floating knee, compartment syndrome, and the polytrauma kid. The obese child, an adolescent, and unstable fracture patterns are sort of quasi-treated with casts in some groups. I will tell you, in our institution, have gotten much more aggressive with the surgical treatments, particularly now that we're pretty good at flexible nailing tibias. I say that we learned how to nail tibias. Tibias are not as easy as femurs in general to get good at, I think. So we learned all the rules, and it's not weight-based or anything. It has a lot to do with fracture pattern and size of the child, but there are other options as well. Distal fibula. So distal fibula is easily the most common. Distal fibulophysis or distal fibula metaphysis, easy to manage. Short leg walking cast, cam boot. I don't really care how you manage it. They mostly do well. There are some bad ones. So occasionally you'll get a bimal equivalent with the deltoid out. And certainly in this adult-ish child, this is a real problem that needs to be fixed. And then bad fibular fractures often come with bad distal tibia fractures. The tibia always trumps the fibula. Okay, so your management is always focused on what happens to the tibia, not the fibula. Salter-Harris 1s and 2s are managed mostly in casts, and I've gotten way away from operating on these because there's really good data to say if you get them close, they're fine. There was some concern, there still is some concern about whether there's some gapping at the physis and whether it's a problem for growth arrest. So there's a paper from the 2000s that said yes. There's a more recent paper that said the gap doesn't probably matter. I'm not sure where to tell you on this. I don't think the gap matters that much. I think overall alignment matters more than the gap. Often if the gap is there, though, there's some malalignment you didn't recognize, like rotation is really the most common one. I fix these. My favorite thing to tell the residents is God made the Thurston Hollow fragment to put fixation. So you can put screws in them. If they're lower, you put pins in them. These articular fractures, in my mind, are all operative. Okay, I know that's an extreme statement, but you have to really pay attention to these. Okay, Salter-Harris 3s and 4s can look very benign until you get their CT scan, and they're not. Okay, so if there's any displacement on a Salter-Harris 3 or 4, they will get fixed in my hands. And then, of course, every time you see a Salter-Harris 3 or 4 that's displaced that you fixed, you need to tell the family that there's probably a 20 or 30% chance you're going to do something else because of a growth arrest. These transitional fractures are relatively straightforward in the sense that I think a lot of these wind up with surgery. To low fractures, or if they're non-displaced, can be treated non-surgically. Triplanes almost always need to be reduced for sure and often fixed because they're articular fractures. It's not the physis, it's the articular surface. And then here's some rules. If you ask me for these slides, I can give them to you, but they basically need to be 4 to 6 weeks managed if they're non-displaced and not treated surgically. And if they're treated surgically, I do fixation. So screws for the low, and then multiple screws for the distal tibial triplanes. A CT scan pre-op here helps you a lot with preoperative planning about where you're going to put screws, how you're going to do the reduction, etc. Talar neck fracture is not common, so I will go through it fast, but most of them are these non-displaced ones. Even in children, however, we do have a risk of AVN that is definitely related to the Hawkins classification system. So if there's dislocation around the talar head or neck, then there's a much higher chance they're going to go on to AVN. There is a good paper that says if they're under 12, they mostly do fine. Okay. And it has a lot to do with energy and not being common. Over 12, though, you need to look at those people as adults and treat them. And here's an older child who needed to be fixed. OCD lesions are sometimes chronic, but often there also is an acute component to it. So you have to pay attention. The anterolateral corner one is the one that's probably acute. I often will MRI them just to see the size of that fragment and decide if it needs something done. Calcaneus fractures, I almost never operate on, okay? The different world than adults, we rarely see them. There is some indications for surgery, but most of these are treated non-surgically, okay? The indications for surgery in my mind are something like this. This is a child who had a high injury where the subtalar joint was basically collapsed, okay? So there's no way that's gonna remodel. Remember, the subtalar joint is articular and is not gonna remodel. Now, I fixed that and the x-ray looked great. Her subtalar joint is really stiff. However, her height of her calcaneus was normal and her growth was restored. There is some indications for fixation in kids, but very limited for calcaneus. And finally, we'll go through metatarsals, but you okay? You're good. Yeah. So metatarsal fractures are about 60% of pediatric foot fractures. Many of them occur in the 5th metatarsal. Most of these are non-surgical. Okay. Where do you get burned on these? So here's the only places you get burned. So here's one that was reported as a non-displaced 2nd metatarsal base fracture, but the Lisfranc was missed. Okay. So Lisfranc injuries do happen in children, but not commonly. They happen more, at least in our experience, as the kids are transitioning, and then certainly when they get into the skeletally mature. Okay. Most of the younger kids will actually fracture the bases of their metatarsals and not the ligaments. But as they age, they get closer and closer to adults. And we see, I think we've had at least 3 or 4 this year alone that we've treated. Megan probably got stuck with all the ones at eye center. So they do well, though, so far, we think. There's not great long-term outcome studies on Lisfrancs in kids, however. We still fix them like a Lisfranc injury and not do an acute fusion, by the way. Who else gets fixed? Articular fractures, those with compartment syndromes, those with severe displacement. Multiple fractures often get fixed. And then we get into 5th metatarsal. So we definitely see these, and most of them still fit into this avulsion fracture category. So the Jones fracture concept of the metaphyseal, diaphyseal junction, or just distal to it, where there's a little bit of watershed for blood flow and low healing rates, we definitely see in kids, but not at the same rate as we do in adults. This paper from Boston actually was interesting. They said, forget about where it is on the bone, measure the tip. to the fracture line. And if there's about less than 20 millimeters, about 4% of them will go on to need surgery and the rest will heal. But if the fracture line is about 20 to 40 millimeters from the tip, then they go on to need surgery about 20% of the time. Most of these heal. If they need surgery, they wind up getting some sort of avulsion fracture fixation. And this is, again, this is an older child that came in with this and it went on to this, which is basically a non-union that had fixation. And finally, the toes. We don't operate on toes much, okay? Occasionally we'll operate on toes if they're articular, if it's very, very displaced, but often these can be treated non-surgically with a little buddy tape, a hard-soled shoe. The most common one that gets operated, we talked about it in the hand as well, but is the Seymour's fracture. We definitely see the stub toe open fracture, Seymour's fracture equivalent in the feet. And we looked at this several years ago in JPO, and there's an infection rate that's much higher in these than there would be even in the hand. Okay, so pay attention to these. Do exactly what the algorithm was for the hand. That's it. Thank you.
I think we'll just get somebody to.
No, they were going to play a video.
Oh, sorry.
We are not supposed to speak. And I don't know, there's somebody who's going to play the video has not been there?
No, sir, no video, just a 10-second pause. That's it.
10-second pause, no problem.
Yeah, you can start now.
Okay, I'll share my screen. Good evening from the side of India and from USA. We have a new team, Jody Segal from North Carolina and Jack Wickstead from Boston. Hi, welcome to both of you. Please make yourselves visible, put on your video and unmute yourself. I'll start with the questions. I'm Dr. Dilip Shah from Mumbai and I'm coordinating this meeting as a moderator. Which are the problems related with technique of suprapatellar tibia nailing? Which are the disadvantages and complications with this technique? This is Dr. Virendra Shukla from Gujarat. I'll stop sharing my screen.
Hi, thanks for having us. I'm guessing that was
directed. Hi, Jody, how are you?
Hi, great. How are you guys?
Oh, fine.
Excellent. So I think that the potential downsides of suprapatellar nailing is what all of the people who don't like to do it say, that you can hurt the articular surface and that you have to open the knee joint. I think as long as you're careful with the knee joint, you don't actually have to denude all the cartilage. And there's plenty of equipment nowadays that you can use to protect the articular surface. So I think the biggest downside is that I need to make sure I continue on the patients afterwards for working on their knee motion, because they can get very stiff because they don't like to move their knee after you do a big arthrotomy. So I think that's a potential downside. But I think as long as you keep talking to the patients, and they work on the knee motion, then the benefits are significantly more than the downsides.
This question is addressed to both of you because it's in continuity with this question. Jack and Jody, both of you, you also must have migrated from 90 degrees flexed position to extended position and going supracondylar. Now, we are used to having 90 degrees of flexion at the knee, and we have traction, which reduces the fracture pretty well. We distract by 1 or 2 millimeters the fracture site, and then introduce the nail. So it becomes very easy. The reduction is never a problem. And to do interlock screw fixation also is so easy. So why at all should I change my approach by supracondylar? Tell me that.
I'll tell you, I'll take a stab at this one for starters because, Dr. Siegel and I used to work together.
And, we had a group of residents, and she would always do the semi-extended nailing, and I would always do the 90 degrees, and then we would sort of teach our residents both techniques. And I changed jobs, and my new residents all asked me, like, how do I do the semi-extended technique? So I started doing it, and I have never looked back because it's just easier. Like, you don't have to wrestle with the leg. The one thing that really makes it easy for the surgeon is the imaging, because now you just move the C-arm, you don't have to move the leg. And I would say, if you haven't done this, give it a try. You'll probably convert and never go back, because it really makes the imaging super easy. You just lay the leg where it belongs and it stays there. And you don't really have to move the leg at all. And when you don't have to move the leg and you just move the C-arm, it makes your case 15 or 20 minutes easier. It's just a faster procedure.
No, but how do you maintain the reduction? Because there is no traction pull which is happening.
Do you guys use...
Go ahead.
Sorry, Jack. But
no, go ahead.
How are you getting your traction? Are you getting it from the table? Like, how are you setting that up?
It is bent to 90 degrees, and we have a rod which is placed at the thigh level, and the foot plate, which is absolutely holding only the foot region. And we apply traction like what we do in trochanteric fractures,
Okay, so you're getting your traction from a table.
Yeah, which gives such an excellent reduction, believe me. And if you distract by 1 millimeter, and once you put the nail, you give a back clap after you have put the interfragmentary screw. And the whole surgery takes less than 10 to 12 minutes.
Right. Well, yeah, when we were doing hyperflexion nailing, we're not using a fracture table.
That's the thing. You see, we have been using fracture table. So I will try supracondylar nailing. If you try this method where you have reduction, you don't have to do anything. And C-arm moves so easily. So there is no point in anybody needs to hold any part of the foot.
Well, and if you're using a fracture table, that's fine. But I think, there is some setup to the fracture table. It requires additional equipment. When I'm doing suprapatellar nailing, I just lay the leg out. And usually when you just lay it right there, it's reduced.
We agree to disagree, but you should also try this method and see in some simpler fractures. You have a fracture table, give traction, and things are done in 10 to 12 minutes. Interfragment is so easy. You will see a full moon, and actually if you keep the drum side very close to the foot and the tube away, you will see a big size full moon.
Yeah, I think, there's how many guys, so just by a show of hands, I don't see a lot of you guys on video, but Subhash, Ananda, are you guys using a fracture table? How are you guys doing it?
In chat box.
So I do the suprapatellar. Once I started using it, it's excellent. Sir, I would request you to try it once. You will never go back to the...
I will try, but the thing is the reduction and the fracture table, which we are used to it.
Sir, it's without the fracture table, suprapatellar is excellent. Once you start using it, you will never go back to the hyperflex position.
Two things I wanted to ask you now. Distal most fractures, we use expert tibia nail, and which has got 30 degrees lateral to medial or medial to lateral. In some of your x-rays, I didn't see that kind of 30 degrees angle. So you have some different nails for distal fractures of tibia?
Jody, you want to raise this one, or you want me to?
Jody, yeah, you can.
Yeah,
you are a nailer. I'm also a nailer.
Yeah, I'm a nailer. I don't know what you're referring to, the expert nail. I don't know what that is.
Yeah, it's the Synthes expert nail, Jody, where there's an oblique. The last hole in the bottom of the nail goes oblique 30 degrees, and you can go either medial lateral or lateral medial. It's just a very distal hole, that's all.
Can you allow me to show that to her if you want?
Well, I would say, in the end, most of the modern nailing systems, no matter what company you get it from, are going to have some very distal option that's going to be, 3 to 5 millimeters above.
Yeah, we call it as tip locking.
Yes, very tip locking. And I don't think it matters whether you use, a nail that was made in Switzerland or a nail that was made in China.
This 30 degrees doesn't have a spatial advantage.
I don't think it has any. It's
okay.
I don't either.
It doesn't matter what company you look. A nail is a nail is a nail. If you use it correctly, it's going to work. And if you use it incorrectly, you're going to get a bad result.
We go to some other question. Okay.
I have a question for you guys. Are you using domestic implants or are you using primarily imported implants?
It's a mixed bag, Jack. We have Smith and Nephew. We got the Zimmer nail. We got
Zimmer nail, Smith and Nephew, but all of them are generally imported unless and until there is restraint by the cost of the implant.
Yeah, I mean, I've done some looking online of the Indian implants, and it looks like there's some options which are quite good quality.
Now there is a question from one very brilliant fellow from Gujarat. I'm going to share that question with you. Jawar Jetwa has asked this question. Can I share that with you?
Sure.
Sure.
I can't see it. Can you hit
I
share?
can't either.
Yeah, I'll show you. Can you see that?
No.
No.
I'll share my screen if you allow me to. Just give me 1 minute.
We were seeing that question a few minutes back, sir. I think.
Yeah. No, there has been some problem.
There we go.
Can you see that now?
Yes. We got it.
Got it? Regarding malunion, or is lost, is there?
I think you might as well say it out.
Okay, I'll read it out for you. Can you see it or not?
No.
You could also cut and paste them into the chat.
Yeah, in chat, somehow it got deleted, so I had to copy them and put them again for you. I'll just share my screen once again. Give me last try and we'll come to that. Regarding malunion, can you see that, sir?
Yeah, sure. So the question here
Literature
really
has not made it clear. First is malreduction and union, and second is loss of reduction and union. A very paradoxical statement, but understand it well, which is common for distal fracture tibia fixation.
Yeah, so the question here I sort of think gets at the issue of, did you reduce it and lose your reduction, or did you just do it poorly in the first place? And the majority of the malunions, I take care of a lot of malunions, and I would say that the majority of these were never reduced in the first place. I think people aren't fussy enough with their reductions, and I think then they accept the poor reduction and put the hardware in. And then it slips a little bit and they blame it on the patient, or, this was unstable and it moved, where I think the majority of these are not well reduced in the first place. And I would say, we're all good at ORIF, and the most important part of that is the R, not the IF. R always comes before IF, so it has to be reduced before you put the nail in it. Your nail, particularly in a distal third or in a very proximal tibia, it's difficult to use the nail to help reduce it. It can be done with blocking screws, certainly, but it's way easier to have it reduced correctly first and then put the hardware in. I don't know, Jody, if you feel differently.
I completely agree. And I think another component of that that's frequently forgotten is just the quality of your imaging, because you can take any oblique x-ray and make something look good and straight. But if you get like standard x-rays and it's crooked, then it's crooked. So just remember that it's AP and lateral, and that's the way we work, and not oblique to make it look straight.
Gurinder, what's your thoughts on that?
I'm fairly confident in what you're saying. You'll actually never end up reducing it. That's the problem that you end up getting. So you hardly ever lose it. Once you fix it well, you don't lose it. Totally agree with you on that.
Particularly if you're locking in multiple planes. And I think for these very distal fractures, anything in the distal, quarter of the tibia, I am using all the distal locking options I can get. I use 2 medial lateral, 1 AP, an oblique if I have it. You won't lose your fixation if you do that, but you will definitely lock in a malreduction.
Agreed.
You're right.
In there.
Still takes the.
And can you see one more question by Jawar Jetwa from Gujarat? How to judge valgus reduction when CM image cannot show knee and ankle joint lines together? So you see by eyeballing, how do you do it?
Well, if I'm worried at all, then I just will get a plain film in the room sterilely so I can see the knee and the joint, or the knee and the ankle at the same time. But I think there's a couple of other tricks out there. There's some radio dense guides that you can, have something that's 90 degrees that you can lay on the ankle or the tibia and send it down the shaft. So there's some other other things, but I would just get an x-ray if you're worried.
Yeah, I have one of these rods that just, attaches and can be the full length of the leg. And I'll just go hip to knee to ankle and make sure that the mechanical axis of the leg is neutral.
Or maybe we can use the equipment of total knee replacement and see.
Yeah. I just have one that extends to, the full length. I used Bovie lines for a long period of time, but it's easy to cheat on the Bovie line. It's a little harder for me to cheat on a rigid rod. So I just use a rigid rod that I have in the back that screws together, and it's about, 3.5 or 4 feet long. So
the last question from Mumbai side, which is asked actually by Jay Kumar from Maharashtra. If the tibia is in vara shape, anatomy wise, how will you tackle this situation? A lot of people have severe varas.
This is an interesting issue because we don't see this nearly as much in the United States. I do a fair number of malunions and I do a fair number of deformity corrections. So I see this in various populations. I have a group from Cape Verde for some reason where they all have vitamin D deficient rickets and they come in with fairly significant varus. And I think if you can't get a nail down that tibia, then I would do a secondary osteotomy so I can get a nail down it. And I don't think that can be done quite simply. I would be curious to see, I'm sure you have much more local experience with this than we do in the United States, but I wouldn't have a hesitation if there was so much varus that I couldn't get a nail down to do an osteotomy to get a nail down. I don't know. Subhash, do you see this periodically?
Yeah, so with this, we see this quite a lot with the elderly patient who are on the osteoporosis and have the femoral as well as the tibial bowing. But if we fix them with a nail, they're slightly opened up like an open wedge osteotomy, and they heal pretty well. I have no issues with the nailing them, no problem at all. But they get slightly lengthened because of the nail. Definitely, yes, because of the open wedge osteotomy sort of picture there.
It's not complicated to figure out where the nail goes. You just put the nail down, and when it stops, you make your osteotomy.
You can do osteotomy there. But the question is, if it's bilaterally symmetrical deformity, would you like to correct one leg?
So I have a bunch of these where you have a distal femoral varus and a proximal tibial varus on both legs. And I will fix one leg perfectly and then do the other leg. And I'll do them at sort of, 4 to 6 month intervals, depending on how well they heal. So, yeah.
Yeah, this is the first round, which is over. If we have time, I'll come back again. May I request Dr. Gurinder Bedi, please start with the questions from Delhi side.
I have a question also for my Indian colleagues. Do you have problems with tibias that are too small to fit a standard size nail? Do you have smaller nails, 7 nails or 8 nails? We tend not to see this in the United States, but I have had a number of patients from Asia where the nail was really tight. Even a small nail was a challenge for me. I don't know what your strategy for that is.
Yeah, you should keep in your armamentarium the thinnest nail which is possible. If you cannot put that nail, then you try and ream to go at least up to 7.5 to 8 so that you can negotiate a 7 number nail. That's the best way out. Or else you keep tibia plating ready or anatomical plating ready, because you don't have to really shatter the cortex in order to negotiate the nail.
Yeah, we don't even have 7 nails available. There might be 7 nails in the pediatric set, but we don't generally, they're not generally long enough. So we don't really even have 7 nails. So
no, you have to really believe to have this kind of very narrow medullary canals. And we do it because I had encountered 1 millimeter size nail cavity in radius and ulna. And he had segmental fracture. It was in 7 pieces. You cannot put a plate right from proximal to distal. So I had to put drill bits, started with very thin drill bit and went up to around 2 millimeter drill bit to put a nail inside. So
hopefully you only ever have 1 of those. You never have 2.
He had osteogenesis imperfecta and had very thin cavity. So it's a challenge. We see various different kind of situations. So Gurinder Bedi, are you ready or not?
Yes, I'm ready, boss. I'm ready.
Come on, sir.
So hey, goes. Jody, tell me, what percentage of nailings, whether it is metaphyseal or diaphyseal, would you actually now treat with the suprapatellar nail compared to the standard? Is it 100% suprapatellar nowadays?
Yes. The only time I do infrapatellar nailing is if I'm doing an exchange nail.
Right. Okay. No, you said the two techniques of doing. Sorry, I'll go with you for the time being.
Guri, can I hold you for a minute? Why in an exchange nail you are moving towards the infrapatellar nail?
I think you can't really get the nail out suprapatellar. You're really going to destroy the knee if you're trying to grab the nail.
I have done it twice, and it's very easy to.
You're braver than I am.
With a suprapatellar nail, even it's very easy, very easy.
I would say in an exchange nail, though, you don't have to worry about the reduction. You're not doing an exchange nail to reduce it. It's already reduced, right? So it's very simple to flex the knee, pull out the nail, put the other one in, because you're not worried about losing your reduction. The whole reason that we're doing suprapatellar nailing is to make the reduction easy and not to lose the reduction, wind up in valgus or flexion. You don't have that problem with an exchange nail. So I really find it's very quick to just make an incision around the
I'm just saying it's equally easy to do with the suprapatellar technique as well. I've done that twice.
I used to tell all my residents that Jody was crazy for only doing suprapatellar nailing. Now I have found somebody who's even more crazy. So that's good.
Nice.
Okay. Just tell me, when you talk about suprapatellar nailing, do you always go and release the medial parapatellar? Have you ever tried just spreading the quads and trying to go underneath the patella? Would you not do that at all?
So I don't do that. Here we call that, what do we call that?
I mean, that's really suprapatellar nailing. What you're doing is
suprapatellar nailing is really when you split the quad, and the semi-extended is when I do a real arthrotomy, a medial parapatellar arthrotomy. And the real difference is that when you split the quadricep, you do it with the knee in full extension. And so if the patient has intact ACL and PCL, then you can't really subluxate the tibia anteriorly on the femur. Then you can't get a standard portal. Your portal ends up being more anterior or distal down the shaft, as opposed to if you flex the knee 30 degrees and do an arthrotomy, then you can actually get to the what's described as the appropriate portal for a tibial nail. So that's the difference to me. I also think it's a little bit more brutal to the joint to split the quad and try to get under the patella, because some people just don't have any space in there, depending on their amount of arthritis and the compliance of their soft tissues.
You actually make a small incision and you put a scissor or a knife around the patella and allow it to come back, and then you try to close it up. Your incision is slightly bigger than if you're doing a medial parapatellar, because you're going to go and stitch it all out at the end of it.
Correct. Yes.
Tell me the articular injuries which you read, encountered, complicated with the suprapatellar. So tell me about the incidence of medial patellar facetal chondral damage and intermeniscal ligament damage. Any literature to quote on this?
So there is a paper that came out of Tampa from Roy Sanders' group where I think that they scoped later. I can't remember if they scoped them or got MRIs or something like that, and reported that there was no difference with their extended nailing versus their infrapatellar nailing. It was very controversial when it came out, and there was a lot of arguing about it. But that's the only thing I've seen about the intra-articular damage.
Okay, tell me, when you combine your mini plates with your in the tibia, aren't you really confusing the two issues between the relative stability and an absolute stability? What you really want is, some amount of movement, micro movement to happen if you got a nail inside. And putting the plate on, does it not interfere with the philosophy of treatment?
Yeah, I think that sort of gets into how stiff of a plate you put on and how much weight bearing the patient's going to do. I tend to find that the provisional plates, I usually remove them if I'm going to use a provisional plate. But I would say there's plenty of instances where I left them in there. And it's nice for us to think in little boxes. I'm in the rigid box. I'm in the not rigid box. But, fracture healing is a continuum of across the whole situation. And I think if you have a relatively flexible plate, like a semitubular plate that's just temporarily holding you in place while you do your reduction, that's not going to provide a lot of stability for you. And I think you're just going to walk around it and you're still going to wind up with a relatively unstable situation. I think if you take a heavy duty LCDCP plate and you lock a malunion in, that's a recipe for a disaster. But that's a pretty unusual situation. I see that mostly in people who try and do percutaneous plating of the distal third of the tibia. And they have a poor reduction, and then they lock it in place with a heavy plate, and then they're worried about their fixation, so they tell the patient not to walk on it for 8 weeks. And that's just a recipe for a mess because you've taken a rigid plate, you've locked the tibia, you've held it gapped open, and you've told the patient not to walk on it. I think if you're using a tibial nail and you use a relatively small plate that's kind of a wimpy plate anyway, and you tell the patient afterwards, walk away on this thing, you're not going to have problems.
Jack, would you say encirclage wiring, like the way we're propagating in femur, is a complete no-no in the tibia?
I think it's hard in the tibia because you could easily grab something bad. You know, those neurovascular structures run right behind the tibia. So my advice on the tibia would be stay the hell away from cerclage wiring because you don't know what you're going to grab back there, and you could really make it a bad situation worse. I think in the femur, it's very forgiving because the neurovascular structures are far away. So I think it's less about, choking off longitudinal blood supply and, cerclaging the periosteum on the tibia, and more about like, am I going to do something bad to this patient, So my advice is stay away from it.
Jack, top three tips for avoiding wound complications and descents in distal tibial fractures. It comes from Vimal in Rajasthan. Your top 3 tips for avoiding a wound descents in the distal part of the tibia.
My first advice is to you have 2 opportunities. You can do it immediately before the patient gets swollen, or you can do it
timing. Second one.
Yeah. I tend not to make big, huge anterior incisions because those big extensile anterior incisions are problematic. I find even just gapping them with 2-3 centimeters. So I'll make a distal incision, skip 2-3 centimeters, make another incision. I tend to find that gives you a lot less wound complications. The other thing I would say is watch out for your spacing. If you're going to be going medial and lateral, you need a big enough gap that you're not going to cause necrosis in the middle.
Are there any good papers that comes from Anupam Srivastava? Any good papers talking about the results of nailing in proximal tibia versus plating in proximal tibia in terms of what gives a better result?
Well, there's a randomized trial which is called Impress, which has been presented at the OTA that I have not seen published yet. So that's coming if it's not like electronic.
Okay.
But I believe that, I saw that presented at the OTA and it was no difference.
No difference. It's about the reduction.
This is about the reduction. If you get a good reduction, you'll get a good result. And, the tibia is pretty, it doesn't really care whether it's held with a plate or a nail proximally, as long as it's well reduced. Crappy reduction is going to give you a crappy result.
Jack, can I make a statement? Distal tibial fractures do not have syndesmotic injuries. True or false?
I would say true.
Okay. So I've actually never put a syndesmotic screw in a distal tibial fractures. I've plated fibulas.
I have put them in. I'm not sure that they're really necessary, but I have plenty put them in. Now, I think you have to make the discrimination between, is this an ankle fracture that happens to extend to the tibia, or is this a tibia fracture that happens to extend into the ankle? And I think if you have a pure rotational ankle fracture that happens to extend proximally, I'm happy to treat it with a nail, but it's an ankle fracture. And, conversely, if I have a tibial shaft fracture that happens to extend down into a posterior malleolar injury, that's a tibial shaft fracture. That's not primarily a rotational ankle injury. I think you're going to have a lot less problems with the ankle in those situations. And in those cases, I would never really use a syndesmotic screw. Jody, I know you've done some thinking about this as well.
Yeah, I would lean towards agreeing with what you said. And every once in a while, there's that weird thing, and then I would just stress it. I have put screws from the fibula into the tibia for some distal things when I need some extra fixation, or the tibia bone is particularly poor, or the patient is particularly not trustworthy. So I would say I've never done it, but I think generally speaking, distal tibia is not a syndesmotic problem.
Go ahead.
You go first. Sorry.
Well, while we're talking about complicated tibia things, and I noticed the time's getting short. I wanted to get your guys' thoughts too, as well, on proximal tibias and using nails around total knees. I've done this now half a dozen times and had pretty good success with it, and I'm just wondering, what the local experience has been.
I'm a plater for periprosthetic fractures too. Plater, 100% plating.
Yeah.
What about if it's a shaft fracture and there just happens to be a total knee in the way?
Plating.
Plate.
Every time.
We get some, we in the United States, we maybe you don't see this so much, but we get some very tremendously heavy patients, bad diabetics, vasculopaths, and you really don't want to be making big incisions on them or even small incisions to get a plate on them, and you want them to weight bear. in those cases, I've been quite happy with putting nails around total knees and just doing standard nailing. As long as the flange of the component doesn't extend too anteriorly, I've been quite happy with that.
Would you ever not plate a fibula? I mean, how would you decide the decision on fibular plating in distal tibial fractures? Some guidelines in terms of how far up would you not plate it and those kind of things?
I would say I rarely plate the fibula for tibia fractures, rarely. Most of the time, there's really just no need to. It's going to heal fine, and it's not an ankle problem, which is how I see the distal fibula. If there's a lot of bending to the fracture for the tibia, like it's a coronal plane stability issue, then I will put a screw up the fibula, like an intramedullary support to the fibula, just to help further stabilize the tibia in coronal plane bending instability.
I would add that I find my indication for fixing the fibula really has very little to do with the fibula and everything to do with the tibia. Some of these ones, I just have a hard time holding them reduced, particularly if they want to flex anteriorly, so you wind up with like an apex posterior angulation. And I find that fixing that sagittal plane malalignment really helps if I just fix the fibula. So if I'm really struggling to maintain my sagittal plane alignment, I just look at the fibula, and sometimes the fibula is either translated anteriorly 100% or badly angulated. And I find in those, I'm talking within 6 or 8 centimeters of the distal plafond, fixing the fibula in those cases really facilitates your sagittal plane alignment. In those cases, I'm happy to fix it.
Thank you so much, Dilip.
Thank you very much, Gurinder, because if we give you an opportunity to ask questions, you will be asking really very nice questions, but everybody should get an opportunity. So should we go to Subhash? Please come over, Subhash.
Thank you, sir. Thank you. And I would say excellent. I think the first thing is clear that the reduction has to be the best for any kind of tibial fractures. Now, the question here is that if you've done a good reduction and there are different types of nail, one is where the locking bolt is not locked in the nail and where the locking bolt is locked in the nail. So yes. Have you seen any difference in the healing in these two different types of nail? Because we have available both types of nail in India now.
Yes, I initially did a few of these locking when they first came out. There was a sleeve system and I was all excited about it and I used them. And I think the non-union rate was higher. So I've gone away from using them entirely and I just don't use them. I don't use the locking nails at all. I just use standard interlocking that don't lock into the nail. Jody?
The nail that we just happen to have on the shelf has some plastic bushing inside the screw hole in the nail. So I use that because it's what I have. Prior to that, I didn't have any issues with this non-locking standard situation.
But any difference with the locking screws, locking bolts?
Not that I've seen. I haven't seen that problem. No.
I tend to think as well, it's going to be more of a problem if you have a simple oblique fracture. Any of the comminuted ones, it doesn't matter whether you're going to lock it or not. You're going to get enough instability just from the nature of the fracture. But I tend to think in the distal simple spiral oblique that locking it in the distal third is probably not necessary and may predispose you to locking in a malunion. And that may have been what I was doing, or locking in a gap. And I tend to think locking in a gap in a simple fracture is going to be a problem.
The next question comes for the gap non-unions only, because you said that you did a shortening for 2 centimeters. Yes. But if it is more than that, what's your preferred technique for an infected non-union? Whether it's
I try
technique or it's an Elizaro or some kind of bone transport. What's the preferred?
Those are theory. You have to individualize those cases. I will do almost whatever I can to acutely shorten them. So I've acutely shortened people 3-4 centimeters. Much more than that becomes very difficult because their skin gets really bunchy and it's hard to close them. But I've done some, pretty dramatic acute shortenings and been happy with it. I think in most of those cases, you're in trouble, right? You have a big gap and you're either going to have to get good with a frame or you're going to have to do masquelet. If you have a healthy patient who's not infected, masquelet technique works very well. And I've used it for gaps of up to 6 or 8 centimeters quite successfully, but the trick is that they're not infected. So if they have a big gap, I don't really care. What I really want is them to be covered. So my number one concern with them at the beginning is not, am I going to shorten them? What am I going to do to get 2 centimeters back? How much can I shorten them? My issue is, how can I cover them by next Tuesday? You know, if they come in on a Saturday, I want them covered by Tuesday. And I need them covered with a good flap. And if you don't have that in your facility, you're going to be in trouble. But these patients who languish, and I know in India it's much more difficult because you don't get these patients sent to you immediately. But, you know, if you see these patients at 10 days or 2 weeks, that ship has already sailed. Those patients are infected. And
but
then
we have now plastic surgeons at almost all the district centers, district headquarters.
Yeah, you've got to be able to flap those patients fast.
Yeah, wound cover is the best thing.
Yeah.
So there's a question from one of the audience, Dr. Anupam, is that sometimes you fix the distal fibula, but then the reduction of the tibia becomes much more difficult. Have you encountered such kind of problem?
Only if I malreduce the fibula. If you get your fibula fixation in there and then all of a sudden you think like, oh shit, I can't get my tibia reduced. What am I? You probably have a malreduction of your fibula.
Of the fibula.
Rip it out, start over again.
So yeah, any experience with the antibiotic impregnated nail by the synthes in these infected or the compound fractures?
Yeah, yeah, I'll do that.
So one by one, yeah, ladies first. Jody.
So I will do an antibiotic-coated, cement-coated nail. Sure, I would say it's usually in desperate salvage situations. Like some of these people just need a nail as opposed to nothing, or their soft tissues can't tolerate an X-fix. So sure, I will do that. I mean, we make our own, and it's, you know, not hard or anything like that. So I think it's desperation only. I've had a couple of partners over the years who will do it acutely in what they call bad hosts or bad wounds. I'm not sure that matters. I've never had to do that, but it's just another option when you're desperate.
Jack?
Yeah, I have a partner of mine who makes fun of me because I take care of a lot of the tibial non-unions that get referred in that really, you know, it's been 6 months or 9 months and patients are getting desperate. And I will go frame, nail, frame, nail, frame, nail, frame, nail. So I've tried it all and none of it works. You just have to keep kicking the can down the street. So if you come up with any magic solutions, let me know. I'll move to India for 6 months and learn them.
So Jody, question for you that what is the size of intracortical screws do you use? Have you ever seen like the shattering of the cortex while putting the tap in or the screw in?
I would say I go as big as I can, which is never usually over a 2.0. Like if I could get a 2.7 in, that would be huge, but I don't think I've ever actually done that.
Yeah.
I've never shattered the cortex. I'm way more likely to pop the head off of the screw. I think it's just about technique for the tap and how you're drilling. I think you're usually looking directly at the bone. So if you're going to miss, then sure, you're going to do bad things to the cortex, but you should be looking at that. I also just think that nobody in the United States taps anything anymore because all screws are self-tapping. So having good technique and remembering that you have to clean the flutes and all of that kind of basic stuff, and then you'll be fine.
The last question is how many screws are minimum required for the distal fragment? 1 or minimum 2?
You know, I put 2 in everybody. I put 2 in everybody unless I need more than 2. I never do 1.
Minimum 2 for you.
Yeah.
If you can't put 2, that means you're going to put a plate.
Yeah, but I'm still going to try to nail it.
No, but if you can't put 2, then you have to put a plate.
But I'm not afraid to not have great screws. Like I can put in a screw in the plate and it's through a bad cortex on one side, and then I can use a washer or I know that it's in there just as a peg. Because I think there's some inherent stability that you're going to get with that, even if it's not like, you know, bomb or bite that you're getting on the screw. Like it's doing something.
Right. Got it.
I think too, you know, there's some, if you're talking distal third tibia fractures, there's a retrospective. It's retrospective. There's not a lot of patients in it, but Tracy Watson's got a paper that looked at non-union rates relative to number of screws in the distal segment. And the non-union rate was clearly higher with 1 screw. So, you know, when I'm dealing with a distal third tibia fracture, you know, like very distal, you know, within 6 or 8 centimeters above the plafond, really quite distal, I will put as many screws in as I can into the nail.
Perfectly,
Yeah.
Thank you all.
Thank you very much, Subhash. Thank you very much, Subhash. And may I request Dr. Ravi from Hyderabad? Dr. Ravi, please come on.
Yeah. Good evening, everybody.
Good evening.
One of my colleagues from Karnataka, Dr. Sitaram Rao, he wants to know your experience with flexible nails.
Well, I've actually never flexi nailed a tibia ever. I've managed to avoid it, so 0.
I have a lot of, I used to do much more flexible nailings when I was taking care of a lot of kids. So I would find any kid under the age of 10, flexible nails worked really nicely for those patients. Look, most of those kids can be handled without flexible nailing, right? Most of them can just take a cast and be totally fine. But occasionally you'd get, an 8-year-old with an open tibia fracture, or, something with a segmental tibia fracture in a 9-year-old. Beyond using them in children, I would never use them in adults, and I wouldn't propose their use in adults. So I don't know. Are you guys using them in adults?
I've seen a couple of people flex nail below a total knee in an adult in desperate situations. So I think it's at least something to think about. Again, as we were talking about those people who just need some type of stability, who have a terrible soft tissue envelope and they can't be casted, and for whatever reason you can't X-fix them. It's at least something else to think about.
I think it would be very unusual
right.
But again, we're dealing with adults who typically are larger stature than most of the patients in Southeast Asia. So I think for many of your patients, that may be a more viable option. If you've got a 6 canal or a 7 canal, that may be a much more reasonable option.
The next question comes from Dr. Ashok Vardhan Reddy.
Dr. Subhash, you are not heard, so let him finish. We are way behind. Okay, sorry. Yeah, go ahead, Ravi.
Yeah, thank you, sir. Dr. Ashok Vardhan Reddy wants to know your choice in comminuted fracture with loss of bone. Is it a primary bone graft, as primary closure with flaps? What is your choice? That's what he's trying to ask.
Yes, no, I understand. I think in those cases where you have loss of bone, it's typically because the fracture is open. So, if it's closed, you're not going to have loss of bone. So even in the comminuted fractures that are closed, I'm perfectly happy to put a nail in them right from the beginning. In my patients who are grossly wide open and have bone loss, my first choice on those patients is flap coverage. Again, I'm not worried about fixation. I'm worried about coverage. Get them closed. And I would say also in those patients, I'm perfectly happy to do a primary shortening, put a temporary frame on them for 4 to 6 weeks, something just short period of time, and then come back and nail them in a shortened position.
Yeah, the next question is from...
Are you going to masculate them mostly, Jody, or what?
I would masculate them. I don't do acute bone grafting in open injuries. I think that's a recipe for infection.
Yeah, so you're going to put a block in there and then come back at 6 weeks and take the block out and do a primary bone graft when you're fairly certain they're not infected.
Yes, and covered.
Yes.
Thank you. The next question that Dr. Ravi Kumar is asking about entry point for tibia in a TK case, TKR, existing TK.
Yeah, so, if you, sometimes you'll see nails that come to you from somebody else, and the nail will be like way too anterior, and their start point was just kind of bad, right? And then the nail wound up a little too anterior, and it's kind of further down the canal, and you just look at it and think like, oh, well, that person didn't do a very good job. That's what I do for a total knee. I just put the wire in a little bit anterior to the flange, and it seems to cause very little problems. And I just sort of think like, okay, if I was a crappy surgeon, how would I do this? And I've had, surprisingly good success with it.
That's tricky.
Yeah, the next question is...
It's a leap of faith. I would say if you are willing to do this, you have to look at the lateral and be very careful with your tibial your tibial base plates, because some of those tibial base plates have a flange which is very anterior. You're not going to get away with it. The ones where the tibial flange comes more posterior or is in the distal 2/3 of the base plate or the posterior 2/3 of the base plate. Those ones, it actually works quite well. You just have to be willing to make your start point a little more distal and a little more, anterior. You have to sink the nail down inside the canal a little bit deeper so that you don't have a prominent nail. This is well described, and you can look it up in the literature. I'm not a genius figuring this out. There's a number of case studies where this is described, and you can look it up on PubMed. It's quite easy.
The next question is about the case with a nail which is already done with wrong entry point. What do you do in that kind of case?
So I have to revise somebody else's poor entry, then I would take it out and make the right entry if I can. If I can't, then I would use blocking screws to fix it so that it's going to sit in the right spot. Because if you don't put it in the right spot, then you're going to end up with malreduction.
Nobody's going to be happy with a malreduction. And if you find somebody's case and it's only 6 weeks old or 8 weeks old and it's wrong, just fix it. Just do it right. Take it out and fix it. Start over again.
Blocking screws.
Yeah, blocking screws. If you have to make a bigger incision so you can see the proximal portion of the tibia to get your start point in the right place, just make a bigger incision and get it right. Sometimes you have to do that.
That's all. Thanks for a very nice interactive session.
I wanted to request Subhash. Subhash, you wanted to make a comment or a question. Subhash, you do it very quickly. Then we switch over to Kolkata. Okay, Kolkata.
Okay.
Kolkata.
Okay, thank you. So first question is from Kishore Kumar, Bihar. She's asking about the common complications of the distal tibial fractures, which is fixed by expert nail or very low interlocking screws in terms of ankle pain.
Yeah, I don't really have a lot of that. I think that now most of these I open them, I make an incision, I look right at them and I clamp them. They're like really extreme nailing distal ones. And they have ankle pain if they have ankle arthritis, but otherwise, like sometimes the bolts irritate them. But for the most part, it's not been something that I've seen.
I think if you have patients who complain a lot of ankle pain, be concerned for non-union. Some of these are comminuted. They're difficult to tell what's really going on, and you may have an undiagnosed non-union that you just haven't really recognized yet.
Dilip, can I make a comment on this?
Okay, go ahead.
So
Subhash will feel bad. Subhash will feel bad.
We'll pass. We'll pass.
Go ahead, Gurinder. Go ahead. We want to hear what Gurinder has to say. Go ahead.
So just saying, you see, the direction of the screws is the problem in the distal tibia because the screws are oblique. You want to put about 3 screws. The oblique screw normally goes and impinges on the fibula. That causes a lot of erosion on the fibula and causes a lot of pain.
Yeah, and I think you can see that when that happens. You actually see it in the fibula.
You need to have an oblique X-ray, sorry, I won't argue on that.
No, it's true. I've had
I agree.
Where the nail is a little rotated, and then you're a little more anteromedial and a little posterolateral, and then you're either in the syndesmosis or into the fibula. And, I've made every mistake at least twice, right? So I'm perfectly happy to say I put some distal locking screws into the fibula, and then the patient was complaining of pain, and then finally I realized, and I pull out the screws.
Okay. The next question is, what is the role of antibiotic beads in what stimulant in the open type 3 tibia fibular fracture?
Is that the role of
local antibiotic beads?
Local antibiotics.
Beads.
Oh, antibiotic beads.
Yeah. So if I had
antibiotic delivery system.
Yeah,
antibiotic delivery system.
Yeah, my strategy for most of these tibia fractures where I'm using a Mascalet technique, I understand that the beads are going to give me more surface area and more antibiotic delivery. I totally understand that. But my goal with most of the cement that I'm using in the tibia is to use a Mascalet technique. And I find that the block gives me a much better place to pack my bone graft into. So I tend not to use beads. I do tend to use blocks. Now, I have plenty of situations where I'm dealing with an infected chronic non-union and I'm putting a frame on. In those cases, I'm more likely to use beads because I'm trying to get higher delivery of antibiotics. So if I need higher delivery of antibiotics, I'll use beads. If I'm planning on a Mascalet technique, I will not use beads. I'll use a block of cement.
agree.
Okay, but in open fractures, for those who are going to become fixed, there is no bone loss at all. So in that case, those calcium sulfite loaded with.
Yeah, those cases, I want good flap coverage. And if my flap coverage allows for me to throw some antibiotic cement in there, I'm perfectly happy to, but I don't make a point of it. And I think the goal on those is good flap coverage. You know, I want an ALT flap on that thing immediately.
This need.
I mean, okay. I put vancomycin powder on every case that I'm closing now. I've just taken to putting vancomycin powder on everything. And I don't, you know, like I've gone full circle on like, this is stupid to like, give me the vancomycin, I want it.
Wow. Wow.
There was a paper presented by, you know, there was a paper presented by Bob O'Toole out of Shock Trauma that looked at local antibiotics in high-risk proximal third tibia fractures, and they were able to decrease their infection rate from like 4% to 2%. I took that as good evidence that local antibiotics are probably helpful and certainly not harmful. So I don't have any compunction about putting vancomycin powder in patients now, particularly in my joint replacements. I'm doing it on every one of them without fail.
Even after the coverage, do you recommend the back suction drainage? There is a wound, there is negative wound pressure therapy along up, even after the closure of the wound. Do you recommend the negative wound pressure therapy?
So Jody, are you using very many incisional vacs?
No, we are not.
My plastic surgeons really like the incisional vacs on their flaps. And they like to hook their drainage, you know, they're always going to drain underneath their flaps, and they'll hook their incisional vac and their drainage underneath their flaps to the same vac machine. And I think that just gives them constant, you know, suction on the vac itself. We're doing that for the flap. We're not really doing that for the tibia. From my standpoint, if I'm making an incision and closing an incision, I don't worry about it so much. But we do use a lot of incisional vacs on the flaps.
Okay. So another question from Lakshan Hasda from Baripada. There is an open tibial condyle fracture fixed with C6 screws along with interlocking nail. What is the time to give weight bearing? Time of weight bearing.
I keep all of my intra-articular fractures non-weight bearing for 12 weeks. It's very regimented for me, just so that it's easier for my staff and my people taking care of me. So I'm like hardcore.
Okay.
I'm a little less hardcore. I look at the patient and I think like, this is looking pretty good. I'll let him start putting some partial weight bearing at like 8 weeks and then 50% at 10 weeks and then full weight bearing at 12 weeks. I'm a little less rigid.
Thank you. Another question is Anindo Devnath from Tripura. There is a prophylactic. Do you recommend prophylactic partial fibulectomy in isolated distal tibial fracture?
Yeah, no, I understand the question. Yeah, so the question is, you know, would you do a segmental fibular osteotomy if you had an isolated tibia fracture without a fibula being involved? For an acute fracture, no. But for all of my non-unions, absolutely. I don't know, Gurinder, what do you do any acute fibular osteotomies?
Never.
Never. No. For non-unions?
Yes.
Jody?
I don't do the fibular osteotomies for anything, and I've heard you go on and on about it for non-unions.
Oh, but if
there is some old paper that says you don't have to do it.
Go ahead, Dr. Shah.
Yeah, the fibular osteotomy is overdone over here. I mean, in fresh fractures also, there are some people who do it. I don't know what's the reason behind it. Unless it's a non-union which you feel will not heal because of the fibula which is intact and the gap which is there in tibia is not going to fill up. There is no role for fibular osteotomy. There are some people who remove a segment of fibula also.
I probably overdo the fibular osteotomy as well, but it's all in non-union cases. I would never do it acutely.
Non-union, absolutely. Yeah.
Subhash, would you ever do that acutely?
Not acutely. Only
I think the consensus is acutely don't do it. Just fix the tibia, get it right.
I thank you very much. This is beyond the time which we were permitted. And if there are any burning questions from anybody, Subhash, Gurinder, Dr. Pal, Ravi, then please raise your hand. Otherwise, we'll just hang on for 1 minute so that I can make my concluding remarks. Both of you were really great. I thank you very much.
Well, thank you so much for inviting us. Really, I really appreciate you inviting us. You know, we've read so much in the news and on the media recently about the problems India is having, and we just hope things settle down quickly for you.
No, it is overrated in news. Don't worry, we all are very safe and comfortable. Don't worry about that, okay?
Well, I can't wait to come back and have some Indian food, so.
You can come to India and have a look. It's not so bad. Today only I had 2 visitors who came to me, and they have come from abroad, and there is no reason to worry really.
Well, India is my favorite place to visit, so.
Okay, then let me make some concluding remarks, and all of you will hang around also. We need to take one selfie as well. We'll take a screenshot. So thank you very much. We had splendid moderators from North, East, South, and West of India. Jody Siegel from Carolina, North Carolina, and Dr. John Wickstead. You were really great. You came at the last moment, but I could incorporate your pictures. I don't know, you will ask me how I got them, but I did it. I thank very much Gurinder Bedi, Dr. A.K. Pal, Dr. Subhash Jangid. If you didn't get the opportunity, but why did you cut down your question? You must ask it. Even if you want to ask again, I'll give you some opportunity. And Dr. Ravi, thank you very much. We had excellent knowledge about distal tibial fractures and below knee trauma, resolving the unsolved. We leave something unsolved. And when you taught us, we learned a lot. But then when you teach us also, I hope you will learn something so that we can really exchange our ideas. And when we join together, me is not me, because if you see the reflection, we are we. My happiness begins when I stop thinking about me and started thinking about we. It's a teamwork, but more so you people, really, Jody and Jack. Jody is, we call it in pair. Both of you in pair were really very well paired. And I thank IPCA for joining all orthopedic surgeons from India, along with AAOS. I thank you very much. This was a real pleasure. So if anybody still has any question, because these people have been so friendly, they will withstand our situation for 1 minute more, so that you don't go kind of neglected. If there is any issue which has been not solved by these people, please ask, feel free.
Yes.
I was just commenting that in India, we have the 7mm nail because of the Indian manufacturer. So if you don't have them, you can call them from India.
Yeah, that's what, in fact, that's very important. You must have the measurement pre-operative, not on the table, not on the table.
Right.
But you can, if at all it is around 6.5, you can ream up to at least 8. Go. And one more important thing is the reaming should not be with too much of power.
We used to have
too much of power.
Yeah, Dilip, if you remember, we had the solid nails from Synthesis at one stage. Synthesis doesn't sell the solid nail. Solid nail was starting at 7.5.
7.7.
Yeah, we used to have those also, but we don't have them anymore.
It's gone. It's gone.
No, we call them UTN. Unreamed tibia nails were of 7 size.
It doesn't exist anymore.
Where you cannot even use a guide wire. You cannot use a guide wire. These are solid nails.
Yep.
Yeah.
But you are not hell-bent upon doing only nailing. Like Jody has also said that she's a nailer. I am also a nailer. But then there are some difficult situations. You have to accept it, that you cannot succeed. You see, there are many other better ways also. So can we have Jody and Jack smiling so that when you speak, you will occupy the front screen, and we can have Jody, you hang around just now, and I'll take a screenshot. All of us can give thumbs up. I'll just take the screenshot.
So you want me to just talk and smile?
No.
Just smile. Just look pretty.
Now, Jack,
just look pretty? That's hard.
Jack, you talk a little bit so that you will come, and we'll take you in center. Jack, can you talk something?
There's generally no problem with getting me to talk. I love the sound of my own voice. I'll continue
Right.
to talk until you tell me to stop. It's sometimes hard to get me to stop talking because
No, I took the print screen and it's done. Okay, fine.
Nice.
So anybody
Good job,
wants him
Jack.
to be center of attraction, I can do it once again. Otherwise, we're done.
Thanks, everyone. This was great.
Bye. Thanks.
Have a
Thanks
great
a lot.
you guys have a
Take
great
care.
day.
Have a great day to both of you, and good night to all of us in India.
Be safe.
And I
Bye.
thank you. Anybody from IPCA is going to give concluding remarks? Meghna?
Thank you again. Be safe.
Namaste.
Thank you, everyone. Thank you, sir,
Ashwini,
for a wonderful evening, and I'm sure that everybody had a great learning. Thank you so much, and good night. And